This is the request. Those of you who have still not taken your seats, can I request you to please be seated? We'd like to start the proceedings of this event the moment we have the audience ready. Our sincere request for those of you who have not yet put your mobile phones on silent mode, at least through the first two panel discussions, we request you to please put your mobile phones on silent mode. Thank you.
For me to see a room packed with audience and if everybody in your heart is completely filled with joy. And on behalf of Waterfalls, Women Foundation, Charity Foundation, Delia, and the Delia Foundation, I take great pleasure to welcome you all to this event to be held follow. Just a short introduction on who we are this morning. As we all know, Women Foundation, the pioneers for the work they do for our organization, Charity Foundation, who does multiple work in different spaces, but known for the fantastic work they do for dialysis, especially for the more economic class people. Delia Foundation, India's largest patient advocacy body, Metroplus, India's largest chain of dialysis centers, with more than 300 plus dialysis centers across the country and internationally, aiming at giving good quality life on dialysis. And moreover, stands for transforming lives for generation for the interest bringing value to innovation in preventive of cardiovascular, renal and metabolic diseases. And once again, on behalf of all of us, I take great pleasure to welcome each one of you to this auspicious occasion. This morning, as we gather here, I'd like to mention we have with us a respected government, a medical specialist, and of course, a lot of patients seated right behind. And this is an event that comes right from the heart because this is a disease at our homes. And this aim of this event is to restrict the disease at our homes so that it does not reach the homes of our neighbors. And this event aims at protecting the future citizens, the children of our country. Today, as we all know, diabetes and hypertension have been normalized across the country. And there is no better ways normalizing children below the age of 13 to have diabetes and hypertension. And this could only be possible with all of us coming together to create a better health system for the children in our country. Thank you. We'd like to take the opportunity to welcome the Principal Secretary, Mr. Gagan Singh, who has been very warm and kind enough to join us this morning. I request you all to kindly put your hands together and welcome sir on stage. Thank you so much, sir, for joining us this morning. Dr. Freddy Morgan, Director of Public Health. A big round of applause. I think Dr. Freddy Morgan has done some great work in non-communicable disease. Dr. Gopala Krishna, is he present also? He will join us shortly. Dr. Georgie Abraham, if you're a nephrologist, there's no way that you don't know about Dr. Georgie Abraham. Dr. Georgie Abraham currently at the Indian Hospital, the father of peritoneal dialysis and some great work for treatment series. We have Dr. P.D. Shivaraman, the Director of Puri Hospital. Every doctor that's coming up on stage has decades of experience and have been mentors for a lot of nephrologists who are currently practicing. Thank you so much, Dr. for joining us. And of course, Dr. Edwin Fernando, Professor, Stanley Medical College. Thank you, Doctor. We also like to welcome our guest of honor, Dr. Westin Chennai, who's been very, very kind enough on the first day to join us this morning. Thank you so much, Westin, for joining us. And I request you to please join us on the dais. As per the Indian traditional custom, we'd like to start with the lighting of the lamp. As we all know, the lighting of the lamp indicates the start of something good. And on this journey to invoke the blessings of the Almighty upon us, I request our dignitaries to kindly join us forward for the lighting of the lamp. Present on the dais. And to begin with, we'd like to honor our Principal Secretary, and we call upon Dr. Arvind Kanchi, who heads the Task Force for India for Preventive Measures for the Kidney Foundation, to please join me on the dais and honor our Principal Secretary, who is our chief guest this morning. Thank you so much, Dr. Arvind. We now request Dr. Westin Chennai to honor our senior nephrologist, Dr. Edwin Fernando. Requesting Mr. Vasant, please honor Mr. Selvanayakam. Thank you, Mr. Vasant. I request our Principal Secretary to please honor Dr. P.D. Shivarani.
Every doctor seated on this dais has contributed a lot to what we are working for this morning, and it's definitely an honor to have them with us. A big hand of applause to all of them. And may I Dr. Selvanayakam to please honor actor Vasant Ravi. To take us one step ahead, I take great pleasure to welcome Mr. Gagandeep Singh Bedi, the Principal Secretary, to please share a few words with us this morning.
Thank you. I'll start with Tamil. மேடையில் இருக்கக்கூடிய என்னுடைய நண்பர் and colleague officer, Director of Public Health, Dr. Selva Vinayakkam அவர்களே, Director of Nephrology, Madras Medical College and earlier Member Secretary of Transplant, Dr. Gopalakrishnan, yes. So, Dr. Georgie Abraham அவர்களே, Dr. T.B. Shivaraman அவர்களே, and Dr. Edwin Fernando, Professor Stanley Medical College அவர்களே, and I was quite pleasantly surprised to meet the famous actor Mr. Vasant Ravi அவர்களே. மற்றும் என்னை அழைப்புதல் கொடுத்துக்கின்ற டேங்கர் ஃபவுண்டேஷனுடைய சுறுசுறுப்பான வேலை செய்திருக்கின்ற நிர்வாகி மேடம் மிஸ்ஸஸ் லதா குமாரசாமி அவர்களே, அண்ட் மேடம் வசந்தி அவர்களே. அதாவது டேங்கர் ஃபவுண்டேஷன் both of them have been coming to me so many times. Sunday வந்து ஒரு நிலைத்துறை I will not agree, but only because of these two ladies and their great work done by the Tanker Foundation, I thought I should be there in part of this function. மேடையில் இருக்கக்கூடிய இதர எல்லா டாக்டர்களே, பெரியவர்களே, நண்பர்களே, உங்கள் அனைவருக்கும் நான் என்னுடைய அன்பான வணக்கத்தை தெரிவித்துக் கொள்கின்றேன். அதாவது கிட்னி டிசீசஸ், chronic kidney diseases, all of you, in fact, besides Tanker Foundation, I find over here that there are many other organizations which have worked a lot. And I see the name of Mohan Foundation, of course Tanker Foundation, Kidney Foundation, then Nephro Plus, and Boehringer Angelheim. It's a German name, I believe, and all of you. உங்கள் அனைவருக்கும் உங்களுடைய நல்ல பணிக்காக முதலில் நான் என்னுடைய வாழ்த்துக்களும் பாராட்டுதலும் தெரிவித்துக் கொள்கின்றேன். குறிப்பாக டேங்கர் ஃபவுண்டேஷன், because I have been associated with them since the time I was Chennai Corporation Commissioner. I believe you have completed 30 years of service today, this year, so it's really creditable. And Chennai Corporation le vandu, when I was Corporation Commissioner, and now I see that your work is there at other parts also of the state also. You have actually set up a number of centers. I am told you have started about 8 or 10 dialysis centers. You have set up 14 dialysis centers, that is what you told me. And the creditable point is that due to yours and all these donors, I believe, இதுவரை கிட்டத்தட்ட 5,39,000 பேருக்கு வந்து டயாலிசிஸ் நடத்துவது உண்மையாக பாராட்டக்கூடிய விஷயம் தான். We need good Samaritans like you, because chronic kidney diseases are, as all of you are the doctors over here, are one of the top 10 killer diseases in our state, in our country itself. I was actually going through various reports and I was told that the death rate from the CKD is 35 for a lakh population in Tamil Nadu, and it is much higher than the figure of 18 in India. But it's one of the top 10 killer diseases in the country, and the top 10 killer diseases, number one of course being the heart attack, pulmonary diseases, strokes, diarrheal diseases, TB, neonatal diseases, low respiratory disease, diabetes, liver, falls, etc. One of the major reasons for the diabetes is the CKD, the chronic kidney diseases. In fact, all of you doctors, you know that chronic kidney diseases are the major cause are being caused because of diabetes, blood pressure, and many other related diseases. So at this point of time, let me just spend 2-3 minutes on what we should do for ensuring that people do not have the chronic kidney disease itself. In my opinion, The two major causes for that being the diabetes and hypertension. It is our duty that these non-communicable diseases have to be controlled. In fact, the data indicates that in Tamil Nadu, the people with diabetes is around 7.7%, plus 10% of the population is having both diabetes and hypertension. So ultimately, 17% of the population is having diabetes. In addition to that, nearly 14% of the population is having hypertension, plus 10% is having hypertension and diabetes. So 14 plus 10, 24% of the population is having hypertension. 24, but so 7 plus 14, 21 plus 10, 31. At least 31% of our population, 31 to 32% of our population, 1/3 of the population in Tamil Nadu is having either hypertension or diabetes, which, if left uncontrolled, can lead to the chronic kidney diseases for which you are having the meeting today. We have to keep our society healthy. So at this point of time, in my opinion, the strategy of the government, of this social society, of all of you, has to be maybe threefold. The first is prevention. Prevention of all these diseases will ultimately lead to chronic kidney diseases. For prevention, what we need is a healthy lifestyle. Through you, I wish to propagate the concept of healthy lifestyle. What does healthy lifestyle mean? Healthy lifestyle means that we should eat well, exercise well. That's the very important aspect. In fact, eat well in terms of reducing all the junk food, the food with lot of salt in that, the food with lot of the unhealthy food that all our younger generation is eating. We should spread the message of eating healthy. That is the first and foremost message. And second is very important is exercise. Our Honorable Minister has started the 8-kilometer health walk system every day. Why is it 8 kilometers health walk? Through you, the message to you is, to everybody, is that if one does exercise, all of you will agree, 8 kilometer means if you walk 8 kilometers, count the watches, the steps on your watch, it will be about 10,000 steps. And this is a concept in Japan, where almost every city has a stretch of 8 kilometers. People come and walk 8 kilometers over there, and thereafter they walk doing the normal household works, office going, etc. So everybody in Japan, I am told, in fact, our Director of Public Health and our Honorable Minister had gone to Japan and they brought this concept and really took on to that. So everybody in Japan walks 10 to 15,000 steps a day. And we do wish that everybody should walk 8 kilometers every day. That lifestyle change. In fact, Tamil Nadu is the first state where in every district headquarters we have made an 8-kilometer pathway stretch in every district, including in Chennai. In fact, our Honorable CM had to start this, and sir, since CM sir was unwell, so our Health Minister and Sports Minister, they started the stretch from Adyar, which starts at the same point and then comes back at the same point, and we are encouraging all the population every day to do walking. So the point that I feel pained about is that still very small fraction of the population is actually into exercising in India. If you go in Europe and Americas, etc., in the morning, you don't find people walking. Everybody is jogging. At least here we want everybody to walk or walk and jog in a day. So this is the first point. The healthy lifestyle and eating right is the first aspect which has to be done to ultimately prevent the diabetes, hypertension and related diseases which can cause the chronic kidney diseases for which you are having this continuous medical education program today. The second aspect, the second cure, I'm going to tell you 3 points. The first is prevention. Prevention I have already told, right eating and good exercise. The second aspect is detecting at the early stage and going for early medication in order to prevent future complications. It is over here that I will mention the concept of Makkalai Thedi Marutvam. நிறைய பேருக்கு தெரியாது மக்களை தேடி மருத்துவம் என்ன பேப்பர்ல கேட்பீங்க. ஆனால் அது என்ன இருக்கு உங்களுக்கு தெரிஞ்சு வைக்கணும், அதனால் நான் உங்களுக்கு சொல்லி வைக்கிறேன். மக்களை தேடி மருத்துவம் மூலமாக, in fact again our Dr. Selva, when I have a lot of respect for, he is a very dynamic officer and he is the one who has been giving us a big helping hand in this. மக்களை தேடி மருத்துவம்ல என்ன பண்ணோம், தமிழ்நாட்டில் ஓவரால் தமிழ்நாடு அரசால் கிட்டத்தட்ட 10,500 women health volunteers தமிழ்நாடு அரசால் நியமிக்கப்பட்டுள்ளன. We give them every month stipend. அவங்களுடைய பணி என்ன, எல்லா அர்பன் ஏரியாஸ் ரூரல் ஏரியாஸ் நாளுந்தோறும் they have to visit each and every household. They are all mostly ladies, women health volunteers. They go to every house. வணக்கம் அம்மா, நான் women health volunteer பேச வரேன். நான் உங்களுக்கு ஒவ்வொரு adultோட பிபியும் சுகரும் செக் பண்ண போறேன். We have given them sugar testing and BP machine. So they in every household they have specific number of houses. They try to cover that every day, and 10 to 20 houses they cover every day. In all the adult population, they check their BP. They are trained for that. They check their sugar level. Whoever is having possible BP and possible sugar, they are asked to come to the nearest hospital or primary health center. நான் உங்களுக்கு ஏற்கனவே சொல்லியிருந்தேன், தமிழ்நாடு கிட்டத்தட்ட 34% பேருக்கு பிபியும் ஹைப்பர் டென்ஷன் இருக்கிறதா வாய்ப்பு இருக்கு. ஆனால் அதுல இருந்து ஈவன் 30% கூட இதுவரை வெளியே கண்டுபிடிக்க முடியவில்லை. நாட் ஓன்லி தமிழ்நாடு, ஆல் ஓவர் அதர் ஸ்டேட்ஸ் ஆல்சோ. தமிழ்நாடு இஸ் மச் மோர் அட்வான்ஸ்ட். So their purpose is that go to each and every house. Those persons who are having BP and or diabetes, check for them, scout for them, identify them, bring to the nearest public primary health center. And in the primary health center, the doctor confirms the existence of diabetes or hypertension and then puts them on the medicine. If they are in the early stage of BP or diabetes, and if they are put on medication, the future complication, and also they are asked to go for proper food, reduction of sugar, proper exercise, then future complications to that person will not be there, and future kidney failures will reduce. I am sure Mrs. Vasanthi and Mrs. Lata Kumaraswamy will agree to me that the number of people needing dialysis is increasing day by day. We want to reverse that cycle. That's the prime purpose. So our மக்களை தேடி மருத்துவம் மூலமாக கடந்த ஒரு வருஷத்துக்கு already we have already completed 1 crore people's check for sugar and diabetes, and we have brought it to fold. You will be happy to know that in the last 1 or 2 years, the Tamil Nadu government's budget for medication for BP and diabetes has increased threefold, because we have brought the people into it. Not that number of patients has increased, but because we have been very proud to identify all the people who were having BP and diabetes, and we have brought it out and we have put them on medication so as to prevent future complications. My heart is pained when I go to the hospitals and see the people getting their toes amputated, foot amputated, leg amputated and all. So all the vascular surgeons are now trying to ensure that at least amputation is prevented by doing vascular surgery, etc. But my heart gets pained. So because of this particular aspect, and Tamil Nadu le eppume konjam adhikama irukum as compared to other states, because we are a rice eating state. So my point is that putting the people on the early medication is the second cure. The first I have told, good food and exercise. The second is early medication. This is the cure to prevent chronic kidney diseases. The third, of course, chronic kidney disease, dialysis then the healthcare system should take care of all our people. When I did my engineering, I found that one of the best professors, he struggled, after we came to know, he struggled to get his dialysis done, and all his money he lost because of the family expenditure for dialysis. He ultimately lost his life. The best teacher I had in my engineering college, he lost his life because he spent all his expenses in getting dialysis. That time it was a very costly system. He suffered. We all contributed as alumni for his treatment, but of course he could not survive because of lost because of kidney disease. But there are good Samaritans like all of you who are over here today, who have put up the dialysis, who have made dialysis easy for everybody. You have got hemodialysis done, And under Makkale Thedi Maruthum, we have also got CAPD, continuous ambulatory peritoneal dialysis. You are having, yes. Sorry, I'm not. Thank you. Yes, ma'am is there. So I am not a doctor, so always it's a tongue twister. How you all, and I am the health secretary, so I have to learn all these tongue twisters also. So these two aspects are there. It has been made easy. And Tamil Nadu, Chennai, it's hemodialysis centers. There are 1,155 hemodialysis machines which we are having. And in year after year, Tamil Nadu government also through the National Health Mission, we are actually putting up more and more hemodialysis machines so that in every city, why only Chennai? Even a small city also, we want dialysis machines to be available with a proper healthcare environment for dialysis machines. In fact, our Honorable Health Minister recently opened a dialysis center in Kalaina Super Specialty Hospital in Gindi, where ultimately 60 machines are being set up. Right now about 30 to 40 machines have already been set up. It's separate for hepatitis B patients also. So this sort of system is there. And under MTM, Makkale Thedi Maruthum Lekude, நிறைய பேர் ஹியூமடாலிசிஸ்க்காக வர முடியலன்னா அவங்களுக்காக சிஏபிடி அங்கே வீட்டில் போயிட்டு அதை பண்ணக்கூடிய ஒரு வசதி மக்களை தேடி மருத்துவத்தில் பண்ண டாக்டர் செல்வா விநாயகம் போன்ற பெரியவர் எங்களோட ஆலோசனை கொடுத்துட்டு அந்த ஒரு சிஸ்டம் கூட ஏற்படுத்தப்படுது. So it's a win-win situation where government, the NGO sector, the private sector, hospitals, everybody is coming together to help the people with the chronic kidney diseases. So it's the right opportunity. It's a very important. And அதாவது இன்னைக்கு முதல்ல நான் சொல்லும்போது அழைப்புதல் கொடுக்கும்போது நான் சில டைம் சண்டே கூட சரி ஒரு நாள் ஐ கேன் சி மை ஃபைல். ஆனால் இங்கே வருவது ரொம்ப ஆர்வத்துடன் நான் வந்திருக்கேன். ஆர்வத்துடன் வருவதாக கூட நான் சொன்னேன். காரணம் நீங்க நிறைய நல்லா செய்யறீங்க. உங்களுடைய இந்த ஒர்க் ஷாப் கண்டினியூஸ் மெடிக்கல் எஜுகேஷன்ல கலந்து கொள்வது அதாவது எங்களுக்கு தான் பெருமையாக இருக்கு. உங்களுடைய நல்ல பணிக்கு பாராட்டுதல் சொல்லக்கூடிய ஒரு வாய்ப்பு எங்களுக்கு கிடைக்கின்றது. ஸோ இதுதான் இது கருதி நான் ஆர்வத்துடன் தான் நீங்க வந்திருக்கேன். உங்களை மட்டுமல்ல இங்கே இருக்கிற யார் யார் இந்த நல்ல பணிக்கா தன்னுடைய டொனேஷன்ஸ் கொடுக்குறீங்க, டயாலிசிஸ் கிட்னி பேஷண்ட்ஸ்க்கு உதவி செய்யறீங்க, எல்லாருக்கும் நான் என்னுடைய பாராட்டுதல் தெரிவித்துக் கொள்கிறேன். மறுபடியும் என்ன அழைப்புதல் கொடுப்பதற்காக உங்க அனைவருக்கும் நான் என்னுடைய நன்றியை தெரிவித்துக் கொள்கிறேன். நன்றி.
Thank you very much, sir. And like you rightly said, I think the envision of putting this event together actually began when the Kidney Warrior Foundation, we have about 10,000 patients across the world at different stages of kidney disease as a part of the foundation. And the last few years, the one thing that we've been noticing is every day we have people coming to join the foundation because that's the speed in which the disease is growing. And that's what was a wake-up call for us to understand that the number of people, hundreds of people wanting to join the foundation every day was not an achievement for us, was a matter of fear and a matter of concern, and that's when in the state of Tamil Nadu. We'll have our nephrologist share a few words with us. Of course, if the doctors refrain from sharing a few words with us, that's also okay, but we'd like to start up with Dr. Georgie.
Good morning, respected Secretary for Health, Ken Dixit, and Dr. Selva Vinayakam, my colleague, senior most medical professional today in this audience, Professor Shivaraman, whom I knew for 30 years, Dr. Edwin Fernando, I call him my younger brother, and the famous actor, Dr. Basant Reddy. Let me just so much insight has been given by our Honorable Health Secretary about the scenario in Tamil corporate sector, MGM Hospital. So he has been selected to be an engineer in Alberta, Canada. He went to the immigration department in Delhi, and the final medical test was found that he looks well. He's my electronic engineer from India. His serum creatinine is 11 milligram. and we couldn't believe that. And the immigration medical officer has told him from Delhi, you go and sort it out and come back. So he has no family history of kidney disease. He studied in an engineering college here. So the question is it his fault, his parents' fault, his institution's fault, or the fault of our setup that this guy's kidney disease was not diagnosed earlier? So this is a question which faces us all the time. The answer to that is already given by our respected health secretary. Go to the home and check and find out who has got kidney disease. Now he needs a transplant. Day before yesterday, I spoke to them. 6 prospective members of his family came forward, and I checked a lot of them. Some of them not knowing they have sugar in the urine. Few of them have already 3+ sugar in the urine. So finally, I selected an aunt whose kidney functions are normal, with the same blood group, and to move forward. So can we change this situation by these meetings and these interactions? That is a question I want to ask you and see that what we can do. Let me just go to many, many years ago. Tamil Nadu has the credit of starting the first transplant in the world, the first dialysis in the world, colleagues, in 1991. So Tamil Nadu has got endless opportunities to take care of patients and people. Let me tell you one more story. What made me to start this Cancer Foundation? 1987, I was at the Toronto hospital one autumn day, and Peter, who is a social worker, calls me and says that, Dr. Georgie, there is a... So I thought, refugee, why should I bother about a refugee? After an hour, I get a stubborn call from him. Dr. Georgie, you haven't seen, please come and see. When I went there, it was a 37-year-old Naidu, a descendant of Indian origin, who has travelled 12,442 kilometers from Fiji to reach Toronto with severe kidney failure and oozing psoriasis all over the world. You can't even look at him because he had so much oozing from the body. So the Canadian healthcare system made me to take care of him. And so he was put immediately on dialysis, and he was put on the list, and he had a transplant done. So this is how the world works, as one world, one people, and one treatment for all over the world. So Tamil Nadu is taking that lead. I was just speaking to Shivaraman. I always look at him with great respect. He is very tall, but at the same time, recently I was giving an endowment lecture in Coimbatore at the Kovai Medical Center. How challenges of doing charity in a corporate setup. You can do it. He's doing it. That's what he was telling. So even though you are working in a corporate setup, you can take these challenges. That's what I did over the last 30 years after starting the Cancer Foundation, along with all of you supporting us. And the successive governments, our Chief Minister, Honorable M. Sali, Health Minister, and Mr. Subramaniam, and along with the next in the hierarchy is Dr. Gagandeep Singh, doing a wonderful, endless job. It is awesome. I say that, we need to move forward. And let me just tell you what are the things we need. I have written a letter to Prime Minister Narendra Modi. I don't know whether the letter reached him, to take this kidney care all over the country. There is a fingerprint a device which I saw in Japan when I went to speak there in June for the Japanese Society of Dialysis meeting. And this fingerprint device can check the creatinine with one drop of blood. So if we have that, it can be taken to the house, as the government is doing, and find out, who has got kidney failure. Just one prick, like the blood sugar. So we need to manufacture that in our state and standardize so that it can be taken to each household rather than, selecting a few people. 2016, I was one of the contributors in the Lancet paper looking at 12 countries in 6 different regions of the world, chronic kidney disease prevalence. In that, it is written that 17% of the Indian population do have chronic kidney disease. So look at 1.4 billion people, how many have kidney disease? And how do we diagnose it? Diagnosis is only by doing the blood test, as I already alluded to what happened to that engineering student. So we need to look at that. So I am suggesting that before they join the college, we should implement that they should all have a blood pressure check and at least a urine test done to make sure that they don't have any abnormality. And this device can be used in every institution to see that whether their students do have kidney disease or not. So this is the way to take things forward, early detection and prevention. And then coming about the first deceased donor, multi-disease donation was done by us at the Madras Medical Mission Hospital in 1995, 2 kidneys and 1 heart transplant. That was the first time in India multi-organ donation was done after the enactment of the TOA Act. So these are all things, which tell us that we can do a lot of things in forward. And also, sir, I was a president of the Indian Society of Transplantation until October. And we are doing the transplant games in Chennai. Dr. Gomadi from Rela Hospital, and so it will be done, it will be conducted, scheduled to be in January or February. And they have already approached the government, and please take it forward. Unfortunately, I have to reveal that. I have written to PT Usha, who comes from Kerala, number of times about this transplant games, and she didn't even call and spoken to her secretary. She did not have the grace to return the letter. And I have been trying through all the connectivity, and they said they will do it. This is 3 months just to write a letter, we approve that. And this hasn't been done. This is the way sometimes the representative of us, who is a parliamentarian, behaves in a way that which is not at all conducive. So I am thinking that who to approach now? Prime Minister Narendra Modi directly tell PT Usha to endorse this. So these are the things which we need to move forward, and administrators like both of you sitting here can take things forward so that we will have a better future. And I think that with this small, and one more thing, Gopalakrishnan, I believe that if you have inscription in Tamil, you spoke wonderful Tamil, I cannot speak that much Tamil, inscription on the back of the MTC buses in Tamil. So a small inscription which Edwin can do to make people aware about kidney disease. So it will be a great, because everybody looks at the back of the bus, not at the front of the bus. So this will help us. And also, Ravi, you have a big role to play in this, because people all see movies. And there are 2 movies which had negative impact, Malayalam movies on cash. This is not a donation. One was by Mammootty, and the other one I don't remember. They made the movie in such a way that nobody should donate organs. This is donor organ. So I brought it to the notice of the film board so many years ago. I don't know what action they took. So these sort of movies should never be promoted in India, which have a negative impact on organ donation. Thank you all. I hope we will have a wonderful time here with interactive discussion. And I thank God for giving us all this opportunity to work together as a nation, one globe, one people, and one disease or whatever it is to move forward. Thank you.
Thank you very much, Dr. Ravi. Can I request our guest of honor, Mr. Westin Ravi, to please share a few words with us.
Good morning, everyone here. It's firstly, foremost, it's an honor, it's a pleasure, and it feels really proud to be here. Firstly, I would like to welcome the dignitaries on the stage, Mr. Gurdeep Singh, the Health Secretary, and Dr. Selva Nayak, sir, Director of Public Health, Dr. Gopalakrishnan, Director of Nephrology, and Member Secretary of Transplants. Okay. And Dr. Shivaraman, sir, and Dr. Edwin Fernando, sir, Professor of Stanley Medical College, and Dr. Georgie Abraham, sir. Firstly, I would like to say a few words about Georgie Abraham, sir. Sir, I'm your student from Ramchandra. Yeah. I hope I'm not a tried student, so you wouldn't be remembering me. Because I took medicine out of, not very keenly I did, but out of my parents' compulsion I did, and society pressure also. So it's very great to listen to your speech after college, because whenever you come to the general medicine class, I remember, so we always used to admire your teachings and the way the pronunciation, the accent, and what makes every speech very interesting. And it's, the speech that you gave just now is nothing less than what I heard many years back. Thank you, sir. It was lovely to see you talking about such insightful things. I mean, more than what sir has given. I don't think so I can give even 10% of whatever that he has told, but still, it's it's firstly, before going into it, I would like to congratulate Tanker Foundation for taking amazing efforts to reach at this point, especially Lata Krishna Swami ma'am and Dr. Vasanthi ma'am. And all of you, though I don't know all of your names, but really, it's an honor. ஏன்னா எனக்கு இங்கே வரும்போது I just came because of Reema. She's an associate filmmaker here. I know Reema, and she invited, and immediately I thought, okay, this is something for a good cause, and நம்ம படிச்சதுக்கு ஏதாவது ஒன்று இந்த இடத்துல பண்ணணும்னு தோணுச்சு. அது இந்த ஈவெண்ட் அட்டென்ட் பண்ணுறது வந்து எனக்கு ரொம்ப முக்கியமாக பட்டுச்சு. ஏன்னா வீட்டில் நான் ப்ராக்டிஸ் பண்ணுறது கிடையாது, படத்துக்குள்ளே போயிட்டேன், நடிக்க போயிட்டேன். சரி, ஏதோ ஒரு விதத்தில் நம்ம படித்தது ஏதாவது ஒரு இடத்துல பிரயோஜனமாக இருக்கும் அப்படின்னு முந்தானத்து கூட ஒரு இன்டர்வியூ, ஒரு யூடியூப் சேனல் இன்டர்வியூவில் பேசிட்டு இருக்கும்போது, படித்தது எப்போவுமே வேஸ்ட்டாக போகாதுங்க, ஏதோ ஒரு இடத்துல கண்டிப்பாக ஹெல்ப்ஃபுல்லாக இருக்கும். அது இந்த மாதிரி ஒரு ஈவெண்ட்டுக்கு, இந்த மாதிரி ஒரு காஸ்க்கு வரும்போது அது ரொம்ப எனக்கு ரொம்ப பெருமையாக இருக்குது. எஸ்பெஷலி with such respectful doctors and higher officials and all that. It's an honor, and all of the rest of the foundations that's been put across on this board. The efforts they're doing it makes us believe that society is still there in the positive framework of mind, that people like this are contributing really huge, and a small contribution is to spread this awareness, to help them even more, to make sure people across all over the world understand the importance of kidney failure, and how crucial it is to get kidney. When a kidney failure happens, to get a kidney transplant done is mentally so stressful, because recently one of my teachers who taught me social science in my school, her son was diagnosed for kidney failure, and her son was working in the US. So right now her son is he's here, and she texted me saying, I'm finding it very tough because he has to leave his job and come here and do the dialysis, and he's unable to find the kidney donor, and how traumatic it is for us, because now he can't go back to work, and he has kids, he has to take care of his family, and he has to be here and undergo the dialysis, and though they have a family donor, but I don't know, for some reasons it did not happen, and mentally she was almost in tears, and this happened just recently, just 10 days back, and it just hit me so hard. Before take is to prevent it from leading to some kind of a kidney failure and kidney disease and all that. So most important thing that I would say is the diet and the fitness regime of our day-to-day activities, because nowadays we spend most of the time on the phone. We can't deny that, and ever since the smartphones have come up, and a lot of entertainment value is added inside the phone, so we don't even step out of the house, not even to collect a Swiggy order even to your gates. It just comes to your doorbell and you just collect it and pick it up. So what are we doing to make sure that சாப்பிட்டா ரொம்ப நல்லது? எனக்கு ரீசெண்டாக இதே மாதிரி ஒரு கிட்னி ப்ரோக்ராம் ரஜினி சார் அட்டென்ட் பண்ணாரு ரீசென்ட்லி. அப்போ ஜெயிலர் ஷூட்டிங் அப்போ சார் என்கிட்ட பேசின ஒரு விஷயம், very well, sir was undergone a transplant, and he was talking about how much trauma that he went through, and it was almost like coming back in form and in shape and giving a huge success. Like Taylor's his charisma, his mental strength, and the support of the doctors that he had, and அவர் இந்த மாதிரி ஒரு கிட்னி ப்ரோக்ராம் போறேன், என்ன பேசலாம், என்ன நீங்க சொல்லுங்க அப்படின்னு கேட்டப்ப சார் என்னோட நீங்க நல்லா பேசுவீங்க, நீங்க என்ன பேச போறீங்க நீங்க சொல்லுங்க சார், அது மாதிரி மேபி ஐ கேன் ஜஸ்ட் give some tips அப்படின்னு. ஸோ அவர் யூ கேன் இட்ஸ் கிளியர் கட் எக்ஸாம்பிள் தட் ரஜினி சாருக்கு ஒரு டிரான்ஸ்பிளான்ட் நடந்திருக்கு அப்படின்னா அவர் கொடுத்த ஸ்பீச்சில் அந்த ஒரு கிட்னி அவேர்னஸ் ஈவெண்ட்ல அவர் கொடுத்த ஸ்பீச் தான் he instigated about to avoid alcohol and the importance of to make sure that you consume very less salt and healthy diet and have a healthy lifestyle. And I think that is very important in today's generation, because we don't eat on time, we don't sleep on time, and we don't wake up on time also. So there's a lot of lifestyle modification that we have to do as a younger generation to make sure that we follow a correct path, and we leading as an example will actually in a way prevent this disease and make sure that we don't fall into this kind of disease and failure, and then it creates nothing but it creates more kind of a mental pressure, not only to the person who's affected, but also to the rest of the family members. And for that, I really feel take the guidance of your family doctor, whoever your family doctor. Make sure that you do a family health checkup at least 6 months in 1 year, once at least, so that it can be controlled. It can be controlled in such a way that you be aware of such conditions, and it is very important. And being here is such an honor, and I hope this kind of awareness program by such foundations keep on going. This is very important. To spread the awareness, to support such organization is our duty, and that's why I'm here. And it's a pleasure. Thank you everyone. Thanks a lot.
Thank you so much, Mr. Vasant Ravi. We'd like to honor all our guests on the dais with a small token of appreciation. Request you all to please give all guests and partners and special applause to our chief guests and our respective doctors in the dais. A big round of applause. Thank you so much, doctors, and thank you so much once again for joining us. We now request you to please join us back in your respective seats. Thank you. to hotel to only keep 4 chairs on the stage, and they can remove the remaining chairs, please. We now move on to our first panel discussion, and it's a very important panel discussion because this is talking about the current practices and the future transformation with the government of Tamil Nadu. As we already heard, our Principal Health Secretary already mentioned to us that on the graph of what is happening in the country, I think Tamil Nadu is heading the graph, and we are setting a tone for the rest of the country to follow. And we should be really proud of ourselves with what the government and the doctors and of course organizations like us are doing currently for public health. And this lovely gentleman and doctor has been a huge role to play in what we are talking about today. Thank you so much, sir. From Boringa, who works on preventive medicine, Dr. Vignesh, to please join us on the panel. We will also have Dr. Gopalakrishnan, Director, Nephrology, Madras Medical College, and Member Secretary of Transcend, who is not yet present for personal reasons, but he will be joining us anytime and he will directly join us on the panel discussion. To take us through the session, we have a senior nephrologist, Dr. Suresh Sankal from Nephroplus, to please join us in the dais as the moderator for this session.
So we'll get going, Maria. Right, morning everybody. So first and foremost, I think we should give a big round of applause to Vasundhara and their team from Kidney Warriors Foundation. The point being, I think one of the first times that we are having patient advocacy group and other stakeholders all in one place. And the conversations we're going to have over the next couple of hours, I'm sure, will be very insightful for all of us. First, a couple of introductory statements. The major mark of development of any country is the health of its citizens. And without doubt, the biggest impactful stakeholder in that is the government. And rightfully so. Public health structure plays a very, very huge role, and Dr. Selvanagam heads that momentum in Tamil Nadu as we speak. So let's get going from where Mr. Gagandeep Singh left us with. Sir, your comments broadly on what Tamil Nadu dialogue in the non-communicable disease policy space, what do you think is happening as we speak? You know, we heard of the team. Broadly, other things.
being measured. So அது பண்ணும்போது பார்த்தோம்னா almost 60 to 70% of the mortality and almost 80% of the suffering is because of the non-communicable disease. So that's a starting point. So particularly எது அதிகமா இருக்கு அப்படின்னு பார்க்கும்போது we have done what WHO instigated study which we call this a SIP survey that has thrown a light on the problem which we are facing in Tamil Nadu. So that is, our secretary already pointed out, 24% of the population as per the survey ranked diabetics and another 10.28% were both hypertension and diabetes. So literally 1/3 of population is not normal, and if we translate this into numbers, roughly around 2.5 crore population of the state is having a problem. This is the problem which we are facing now. And two related problem is that either you are diabetic or hypertensive, it is known only 50% of them, it is known only when you are tested. It's an asymptomatic. So நம்ம எப்பயாவது டெஸ்ட் பண்ணா மட்டும்தான் நம்ம 100 பேர்ல 50% மக்களுக்கு டெஸ்ட் பண்ணா மட்டும்தான் தெரியும். See, unless you test என்ன ஆகும் நமக்கும் தெரியாது. Nephropathy or neuropathy or retinopathy, இதெல்லாம் முடிஞ்ச பிறகுதான் தெரியும். So this is essential for your diagnosis. So what you have done is one. So once we know the problem, we already have a non-communicable disease program, but still we thought is to make two things happen. One, earlier diagnosis பண்ணோம், and there are many people who are not come into the system. We need to reach them. So அதுக்காக தான் this we brought in this மக்களை தேடி மருத்துவம். That is, our volunteer will reach out all 30 plus population door to door. We have a line list. So we'll do a minimal simple testing. உங்களுக்கு glucometerல test பண்ணிடுவோம், BP பார்த்துருவோம். Further, if you want, we'll move them to the primary health center, where as per the protocol, we'll test them for all basic tests and we'll start the initiation. இதுல இன்னொன்னு என்ன பண்ணா, we will not stop with that. We will ensure that the drug delivery is done in the doorsteps if they are not able to collect it, and all the recent developed drugs are available, which I learned in the beginning.
So if I may ask, with the Makkalai Thedi Maruthuvam, for those of you in English, Makkalai Thedi Maruthuvam is actually healthcare coming to the people. I mean, that's a very how many, what is the reach out of the
number, sir? இப்போதைக்கு we have a line list of nearly 1.16 crore population. That is 55 லட்சம் hypertension, ஒரு 26 லட்சம் டயபெட்டிஸோ, something around 30 lakhs having both. So 1.16 கோடி மக்கள் தமிழ்நாட்டில் இப்போ நம்மளோட அந்த எஃபர்ட் எடுத்ததுல கண்டுபிடிச்சிருக்கோம். So this is a big number. இது ஏன் ஒரு முறை நான் சொல்றேன்?
Go ahead. No, you can finish. No, finish.
Okay. So the business number, இவங்க எல்லாரும் இந்த 1.16 கோடிக்கும் நம்ம மருந்து மாத்திரையை தொடர்ந்து கொடுத்தா மட்டும்தான் we will stop from this getting the complications. இது ஏன்னா, in fact, I have associated with the insurance through which we support those dialysis and other programs.
Correct.
Dialysisக்கு மட்டுமே we'll be spending not less than 15 to 20 crores in a month. That's the amount which is spent on the dialysis. So this is not sustainable. See, இப்போ நீங்க நிறைய பேர் வாலண்டரியா வரீங்க, சப்போர்ட் பண்றீங்க, CSR பண்ணீங்கனாலும் this financially it is not sustainable. See, forget about the challenges which the individual or the family undergo. Finance is the big issue even for the government. So இத தடுக்கணும்னா, see, only one route is that we need to diagnose them, prevent them with risk factor prevention, and if you diagnose them, try to treat them at the early.
And I'm sure what you spend on medications on hypertension is much less than what you need to spend on dialysis,
Definitely,
right?
Definitely.
No, I think the point for a lot of us is, speaking of health for all, health indicators in Tamil Nadu, I'm sure Sir will agree, is not in the top 10 percentile in the country, in the state. And naturally, Tamil Nadu always spearheads all these novel programs that from where what would be your broader message for other states as Vasundhara's team goes? With regards to, what they might, there's always whoever leads carries the burden of the maximum learning, the learning curve.
Yeah.
So what would you say, okay, this worked, but this we learned?
With my almost 30 years of experience in the government sector, the two things which are really brought in. See, one is the political support. See, whatever may be the government in Tamil Nadu, all the government supports the health program. So that's the biggest advantage the state of Tamil Nadu is having. Two, the bureaucrats. See, he is a health secretary for a recent time, but he is able to understand the priorities of the state. See, he is talking about health intervention, risk factor prevention, and what exactly the program is doing. So this is the biggest, the thing which government can do it, and we as a technocrats, definitely whatever innovative ideas if we are able to throw it on, they are there to take it up and financially supported. See, இப்போ இந்த மக்களை தேடி மருத்துவம் கொடுக்கலான்னு சொல்லும்போது it has got a huge challenge. See, bringing in almost 10 to 20,000 volunteers, reaching out 8 crore population is not a small task. See, this being able to support it, that's a...
And bumps on the road, and what do you think of the bumps on the road? This is something that we could have done better as you have gone through the program.
There will be. See, always, if you are handling a bigger programs, spread across the country, spread across the state, there will be challenges, but we are there to overcome the challenges. Definitely we overcome. The small things will get sorted out when you are moving forward.
Yeah, I think we truly have to give a round of applause to the Tamil Nadu, I think, government leadership, as he said, that includes the politicians, irrespective of the party, of course, the bureaucrats, be it Dr. Ramding Singh or Mr. Radhakrishnan who leads, and of course, like Dr. Selvanagam. Let me just move to Jignesh. Jignesh is from the private sector pharmaceutical industry, and he represents Boringa today. Where is the private pharma moving in terms of upstream intervention of NCDs? The reason how we talk is, medications and technological advances come for the latter solutions, what we call once a disease is manifested. Upstream, how is the direction, what activities there?
Yeah, thank you. Thank you so much for the question, and thank you so much to the organizers. It's beyond honor for us to be a part of this wonderful cause of transforming lives. And from pharmaceutical organizations, the basic expectation would be to bring solutions from bench to bedside and take the learnings from bedside to bench, which is probably the upstream part that we are referring to here. Now, the legs on which these solutions would come into being would be innovation. Yes, hello.
Welcome Dr. Gopalakrishnan, who's Director of the Institute of Nephrology at Madras Medical College, and he was also the Member Secretary of TransTan, Tamil Nadu's transplant network. Go ahead, Jignesh.
Yeah, thank you, sir. So I was referring to innovation as well as quality. These are the essential legs on which the solutions would come into being. But innovation and quality itself would not be enough. We also need hands to make these things happen and create value in clinical practice and in clinical care. And these hands would be, firstly, education, larger education of different stakeholders, including the physicians, medical fraternity, the patients, the policymakers. In programs like this, I believe this is a very important aspect of ensuring the value is created in practice. And secondly, some practical solutions. And I'd like to quote an anecdote here. Dr. Gopalakrishnan sir is here. And sir, we often talk about, of course, we always talk about measuring the eGFR value from serum creatinine levels using the formula. And that formula is now available in a very simple app which the doctors would want to use in their practice. But we deal extensively in diabetes care, and there we have found this insight so many times, so often with the doctors, that in front of their patients who are sitting with diabetes in the busy OPD, they would not want to take out their phone and open that website to calculate the eGFR. And that's where a very practical solution, like a kind of desk chart, wherein for every age of the individual and every serum creatinine level, if we are able to...
The whole of India, he's probably one of the most prolific publisher, very passionate about the science of renal medicine, and he leads the largest nephrology training program in Tamil Nadu, arguably among the largest in the country. His legacy will live on with the nephrologists that he trains and builds. And I know he and Dr. Selvanagam together had a screening program on CKD around the state, which gives us a magnitude of the CKD problem in the state. Do you want to comment on that, sir? Yes, CKD screening, because that, again, one of the things in Indian healthcare is a lack of data. And I think that's where this was very helpful.
Thank you very much. First of all, my apologies for being late due to some urgent personal work. Respected DPHR, Suresh, and the other panelists, and thank the foundation and the organizers of this wonderful meeting on a Sunday morning. First of all, I'm pleasantly surprised that, there is not many such programs being organized. There's no dearth of the regular didactic lectures and CMEs and so on. This is with a different purpose, and I'm really, it's so heartening to be part of this important program, because this is very important. This is the way we have to go. Let me deviate from the actual question which you have asked for.
I share your thoughts.
Why I say this is that we all know India is not a country; it is a subcontinent, harboring 1/6 of the entire mankind, and the most populous country in the world. And even though the medical infrastructure, capacity building, the number of medical schools, and the treatment, access to common man, everything is happening. But take it from me, whatever be the advancements we are envisaging and even executing, it will not be enough. That is the enormity of the so-called the non-communicable disease burden India is facing. Of course, it is not the problem kind of confined to India alone. The entire world is facing, but India particularly is a special risk for this non-communicable disease. Normally, we use the expression epidemics, talk about, he's an expert in epidemics, communicable diseases. We use the word epidemic, meaning the cluster, occurrence of a particular disease in greater number during a particular time in a particular zone, particular country or something like that. But we are using the word epidemic communicable diseases. In fact, it's a global pandemic. The diabetes and hypertension, the cardiovascular disease, the chronic kidney disease, and the cancers. And the government of India, as well as particularly government of Tamil Nadu, is very, very particular in addressing this global burden of CKD. I'm one of the global burden of disease collaborators. I've been glad to be part of many capstone papers published in Lancet and so on. See, the data which we are getting, which we are emerging from different parts of the world, particularly from India, is alarming. As Suresh pointed out, we are in the midst of the CKD crisis. The magnitude of the CKD problem is nothing short of a crisis. Why I am saying that? Within few years, I wouldn't be surprised if we reach a stage that everybody we have to consider CKD unless proved otherwise. So that is the alarming situation we are going through. And in India, there is paucity of literature and published data on the magnitude of CKD. So what we decided is that with the help of our respected and beloved Director of Public Health, the Institute of Communicative Medicine, Madras Medical College, came forward to help us in one of the dream projects of Institute of Nephrology. So we all joined hands. It was a mega work, the mammoth proportion. Some 700 to 800 people were involved in that work. What that work is, the first ever time in the country, our country, a statewide CKD prevalence study was planned, and that has been conducted, and it's over now.
I think all of you need to realize this is the first time in a country something was done. I think you have to give a huge round of applause. It was truly big news in the nephrology community when this came out from the state. The
study was conceptualized by the faculty and staff of nephrology and community medicine Madras Medical College, and the execution, 95% of the execution was done by the workforce under our respected Directorate of Public Health. And the Directorate of Public Health in Tamil Nadu is far ahead of their counterparts in the rest of the country. In fact, the vibrant, the young, the medical force in the primary health centers, the achievements of them enormous. You all might be knowing only about a successful immunization, but beyond that, so many programs, all the national programs, ultimately the national programs will become as successful programs only if there is execution happening at the root level. That's happening in the primary health centers under the stewardship of our Director of Public Health. How many PHCs are totally? 1,000?
2,286.
2,286. So what we did is that we wanted to roll out, they find the CKD prevalence of Tamil Nadu in adults. So the study population was adults more than 18 years. So the methodology is the randomized cluster sampling technique, the so-called STEP survey. It is a WHO approved the protocol, and it involves a lot of labor. Why I say that is that, so the entire Tamil Nadu was divided into 144 clusters from Kanyakumari to Chennai. We took care of every aspect of it, First we prepared a questionnaire, a detailed questionnaire to understand the epidemiology, the personal habits and the kidney toxic lifestyle, the profession, exposure to heat and consumption of alcohol, smoking and alternate medicines. It was a very detailed history questionnaire. It was prepared in English, then translated in Tamil, back translated in English, so that, nothing, it's good. Then it was piloted to understand it is okay, this kind of a questionnaire is okay, it is being understood by the common man. So that is the initial preparation. Then we went through, we organized a series of web meetings SAR had organized a meeting involving the Deputy Director of Health Services, DDHS of all the health districts, so that every step of the entire exercise was explained in detail. If you know how to check blood pressure and urine analysis at the spot itself, and how to make entries. It was all, they Google, it was all digital, no paper, and anthropometric measurements and so on. So to simply, what we did is that in the clusters, urban clusters were there, rural clusters were there, and every step there was randomization. In the rural meaning, in the cluster, a particular village is selected, randomized. In the village, the geographic mapping of that selected village is done, and then a particular street is randomized. In a street, house will be randomized, and in the house, a particular individual will be randomized. So like that, it was a very a robust scientific technique, methodology was adopted. So that the sample, the representative sample, it was around 5,500. They actually, whatever data you get, actually, it represents the data of the adults of Tamil Nadu.
I think it's a lot more richer science than our exit polls.
Exactly, almost like psephology. Almost like psephology.
So what are the numbers, macro numbers the early trends that you're seeing?
Yeah, and the questionnaire, meaning, and all the epidemiological data we could gather, and the blood pressure measured, height and weight and body mass index, urine analysis by dipstick, and then blood was drawn, and all the samples were transported to the Central Public Health Laboratory, again thanks to Directorate of Public Health, where there is an automated analyzer, and it was IDMS traceable serum creatinine was done, so that, the standardized.
I think in a gist, it's truly, in a scientific sense, an extremely high quality evidence to know the truth about kidney disease.
Yeah. The worrying facts is that near about 30%, or some 28%, 28.5%, there was hypertension, 18% diabetes, and overweight, pre-obesity and obesity. These three categories put together, 62%. And the CKD-AP formula only we used.
As a query, was rural Tamil Nadu very
no rural-urban divide in this.
I think that's a very striking thing that's happening in India now.
And
the concept of rural and urban, the gap is closing.
Yes, CKD stage 3, 4, and 5, 6.8% of Tamil Nadu adults. Pretty high.
In numbers, how will it transfer to 6% of Tamil Nadu is what?
8 crore population.
Will be adults, right? Will be adults will be like 5 million, right?
8.6 crore.
Yeah, so it's 6% of 5 crores.
6.8.
Yeah, so it's nearly...
That's pretty high. Stage 3, 4, and 5.
Yeah, somewhere in the range of 30-40 million.
And the difficulty in that is that to define somebody as having chronic kidney disease, one-time testing is not enough. So first phase, we did all this. Those who showed abnormalities in the urine and or a drop in GFR, there is abnormality in the serum creat, we went ahead testing them again after 3 months, because to the definition of CKD, there should be a persistent abnormality at least for 3 months. So it was a very big experience and exercise, that's what I mean. And another eye-opener is that we are talking about the lifestyle diseases, hypertension, diabetes, leading to chronic kidney disease and cardiovascular disease. Yes, that is true. And across the globe, the number one cause for CKD is diabetes. Fine. But in our study, 52% of the patients in whom CKD was diagnosed, they had neither diabetes nor hypertension. So
other reasons.
The CKD.
Maybe for the audience, if you could just dwell upon in a couple of minutes, sir, the whole concept of CKD-U. I think there is also some work happening there in the Tamil Nadu government and under the health system projects I'm aware of. Maybe I think for the audience or the broader education, I think that's another thing you can touch upon in a couple of minutes.
Diabetes is the most common cause for CKD. Can you get it? Yeah, most common cause for chronic kidney disease, you all know. The previous reports, as per the previous reports and reports from across different parts of the globe, 1/3 of CKD is due to diabetes, roughly about 30 to 35%. It is there. So the prevalence of diabetes has increased in Tamil Nadu by 44% over the past 2 decades. This is yet another Lancet paper published in Lancet. I am one of the authors for that. And the distribution of diabetes prevalence in the country is not uniform. There are 3-4 states where the prevalence is far ahead of the national average. Tamil Nadu, Kerala, Maharashtra. We are the red zone.
The more developed states, it's a price of development.
So that's it. And hypertension and obesity, all these can cause for CKD. So why this high prevalence of CKD? So there are 2 broad categories. There are so many etiologies, so many causes for kidney disease and kidney failure. I would like to summarize the whole lot of causes into 2 broad categories. The number 1 category, the lifestyle diseases, diabetes, hypertension, obesity, all put together. That is still there. That is a major problem. All these long years, we have been thinking that is the only villain we are going to fight with. Now, equally formidable another culprit, another villain that is emerging, that is called CKD-U, meaning the CKD-U is a small letter U, chronic kidney disease of unknown etiology or undetermined etiology or uncertain cause. This we call it as CKD-U. For instance, all the common causes for kidney disease in a particular patient you rule out, no hypertension, no diabetes, no consumption of kidney unfriendly medicines for a long time, and some glomerular diseases and the birth defects, which we call it as congenital anomalies and inherited disease. All these have been ruled out, but still somebody presents with kidney failure. This number is on the rise every day. No obvious cause. This is CKD-U.
Yeah, it's a puzzling subset that kidney specialists are seeing world over. We call it hotspots. It's reported in Nicaragua, it's reported in Sri Lanka, and even in India was something from Andhra Pradesh, and Serge working on that project in Tamil Nadu.
Initially, it was first reported in the Latin American countries, which is called Mesoamerican nephropathy, then Nicaragua, Ecuador, and El Salvador, and so on, in sugarcane workers. Then subsequently, our neighboring state, Andhra, Srikakulam district, they came up with a big number of this kind of a CKD-U in Srikakulam district, which we call as Udhanam nephropathy. That region is called Udhanam. And then in Tamil Nadu, there are many hotspots. From JIPMER, they have published something called Thondai Mandalam nephropathy. The districts of Vilpuram, Kadalur, Pondicherry, and all that, Vellore, and that's a cluster. Now we know almost the entire, it's not hotspot, the entire Tamil Nadu is a hot state for CKD. Even though we say this category, we don't know the exact cause for kidney disease, there are certain assumptions, emerging evidence in favor of being kind of accepted as the causative mechanisms for the CKD-U. There are 3. Number 1, heat stress. Exposure to high temperature for long hours in a day and for many months or years in a profession. So who is more vulnerable for the CKD-U? The men, more in men than women, and who work outdoors for long hours. Particularly 2 sections are vulnerable. One is the agricultural laborers, then the construction laborers. Then the unorganized sector workers engaged in road laying, foundries and furnaces and factories, truck drivers driving non-air conditioned vehicles, and so on. One commonality is that they are outdoors getting exposed to the environment. Number 1, heat stress. You may ask why this number is more now, unlike in the yester years, the same profession they have been engaged in. But you all know every year the peak temperature is increasing. Every year the summers are becoming longer. We are all perceiving, right?
Silent climate change and kidney impact.
Yes, it is the result of the climate change. So that is number 1, heat stress without adequate hydration. So a perennial dehydration with peaks of dehydration leading on to some muscle damage, and so many things are happening. So that is called heat stress nephropathy. So this is number 1. Number 2, when they are exposed to the external environment, they get exposed to a lot of environmental pollution. Environmental pollution is a killer. Environmental pollution is linked with heart disease, cancers, neurodegenerative disease, chronic kidney disease, so many things.
And I will agree that's one of the hardest thing to measure in terms of connecting, because you can't quantify, we've not developed methods. And what would be the third, sir? I'd like to move to Vignesh.
Yes. Yeah. The third thing is that exposure to the chemicals in life, particularly the pesticides and fertilizers in agriculture and so many chemicals. So these are the three major causes for CKD. That's what.
I think it's a toxic mix between the heat stress, the pollutants, and also the chemical exposure. And I think it's a burning question in global nephrology, how to find the answer. And I'm sure we'll learn a lot from Dr. Gopalakrishnan in science. Let me just two more questions before we close the session. Jignesh, how do you foresee creating synergies across stakeholders? You're from the private pharma, there's government, there is, I'm from the private sector and certain government. Thoughts or any things that that your organization or other pharma has worked globally?
Yeah. No, so obviously opportunities are immense, be it in terms of research, and again, Dr. Gopalakrishnan sir, as you have mentioned, you would also agree that CKD is a very, very heterogeneous disease. We cannot have one solution that fits all. So research and innovation is very important, and for this academic partnerships with patient organizations to see how solutions are actually impacting the patient lives, not only the outcomes of the disease. These are very important for us and for pharmaceuticals at large. Opportunities for education, interdisciplinary collaborative education on prevention of CKD, and as we say, a stitch in time saves 9. What is that time and what is that stitch which is required, which will save 9? In all these diseases that we are talking about, be it diabetes, hypertension, cholesterol, cardiovascular disease in diabetes, CKD, all these are silent for a long period of time, often, before they actually create damage, and the damage is, it's beyond reversal. So
no, I think I, for one, believe point-of-care testing is a technology that is going to be the huge disruption, because that is what is needed. Dr. Gopalakrishnan's project talked about taking blood from somewhere and bringing to a centralized lab. Dr. Selvanagam has to said. I think point-of-care will take you your creatinine and this thing checked just at home, integrated into the MTM. I'm sure that will be a reality soon. Sir, maybe I'll ask you for one last comment linked to what Mr. Gagandeep Singh mentioned, which is the drug medications used. I think a lot of the audience may not know of how Tamil Nadu procures and supplies medicines, because I think that's again a model. See, I think Vasundhara always keeps saying, when we take it to one city or a group, we want to have the learnings so that we can carry it to other places. So I think that is one important thing, which is I think a path-breaking one that Tamil Nadu works on.
Yes.
The TNMSE model, and how it is helping your NCD epidemic handling.
TNMC model, it is a bulk purchase. See, our drug budget will be not less than 150 crores in a year. See, whatever you purchase in the market, the same quality, in fact, it will be better quality. We have a blind quality checking. At the not less than 100 times lesser the price. நான் ஒரு மாத்திரை $1 for which you will be buying it in the market not less than 100 to 200 rupees. It's mainly because of the quantum we purchase, and we have more than 12,000 institutions across the state. So எங்களோட பண்றதால the value is very less, and we will go with நம்ம லூஸ் பேக்லாம் முன்னாடி நினைச்சிட்டு இருப்போம், அந்த மாதிரிலாம் கிடையாது. It's all strip pack with the blister packs with the quality counter checked all the levels. Even after the supply, we'll do one more blind counter checking of the quality. This is one part. Sir was talking about the burden. Technically, we have people like him who have done not only the survey. See, we are able to support it because we have a manpower. Say, I have around 1 lakh employees working under us across the state. Definitely, we can able to do that. But these are the people who designed this, and now we understand the burden. So, support pandradhukku we already have a program under insurance where we support our dialysis ella support pandrom. So, we give approval for 8 cycles at the rate of 8,800, and we also support renal transplantation at the rate of 4 lakhs per individual. In fact, I had a remembrance with the Tanker Foundation when they were trying to work with GCC. We have entered into an MOE where we will take care of all their expenditures totally. So in fact, adilava or 75% will go to the Tanker Foundation and 25% will go to the GCC. See, not only here, so entire state almost இப்போ இந்த 10 மாசம் கணக்கு எடுத்துக்கினாவே roughly around 2 lakhs approvals you will given only for the hemodialysis. So which translate into something around 150 to 160 crores. But இது ஏன் மறுபடியும் சொல்றேன்னா, see 10 மாசத்துல 150 crores spend பண்ணி hemodialysis கொடுத்து அந்த மக்களும் கஷ்டப்படுறதை விட இப்போ I'm able to invest the same 150 crores in a primary care and prevention, it will be a huge savings and huge suffering prevention to the community.
I think this is only,
this is the message which we...
scale, low cost and extremely wide outreach. I think that is the tremendous thing of what is happening in Tamil Nadu government intervention.
And you are talking about the point-up CAT device. Yes, we can measure the creatinine, that's already there, but it needs some more sensitivity and specific testing in our... But we have started with another low-cost intervention 3-4 months back. That is, test all 30 plus population who are coming into our institution for a urine. So heuristic is already part of our supply. In the 3 மாசத்துல மட்டும், see we have around, I have around almost 8,700 health sub centers and 2,200 primary health centers under control. So இதுல இந்த 3 மாசத்துல பண்ண மட்டும் இந்த urine 1+2+ வந்தது மட்டுமே 3,700 பேர். So this is the burden which you have failed to detect. So if you are able to do this even small interventions, definitely we can able to prevent a big epidemic. These are things which can be done.
I think there's a lot of public health action in motion in Tamil Nadu, and I'm sure we'll continue to learn a lot from them. I think we'll call it time. Thank you very much, sir, and thank you, Dr. Gopalakrishnan and Jignesh, for the session. You want to have a... Please.
Thank you very much, Suresh, for the session. And this session was about the current practices and the future transformation with the Government of India, along with the medical specialities. And a special thanks to all our panelists on the dais for sharing the current system with us. Thank you. Thank you, Doc. Doc, I'll come and meet you, Doc, in the office. Without further delay, we'd like to move on to our next panel discussion, and we first like to call upon our moderator to join us on stage. Please put your hands together and welcome Dr. Balaji, nephrologist from Kaveri Hospital. And on the panel we have Dr. Murli, Dr. Sita, Dr. Gupati, and representing Tiruchi, we have Dr. Sandal Kumar. We understand Dr. Gupati also has an international cardiology conference to attend, so in case we have him moving off the panel discussion, we just keep in mind that he's attending another conference. We also have the patient body, Mr. Sunil Kumar, to join us on this panel. Sunil Kumar is a 2 times transplant patient, non-diabetic, secondary hypertension, which means hypertension was not the primary lifestyle disease, and the reason he's on the panel because he's also an aortic dissection survivor, type A, and hypertension has been a very critical part of his journey from the first transplant to the second. Thank you.
Thank you, Kidney Warrior Foundation, for giving me this opportunity for this panel discussion. Good morning, panelists, and good morning, sir. So we are here to talk about how hypertension is an important risk factor for the cause and the progression of kidney disease. Let me start with our patient first. We were told that every panel discussion has most likely a patient to make it more interactive. In your words, who should detect hypertension first, and what you should do?
It's a good question, but unfortunately, I'm on the other spectrum of...
I know, I understand, yes.
So
I thought you could give a bird's eye view of how the public would think.
No, the reason is why I'm telling this because I was a sportsman. I was leading a very healthy lifestyle, and I realized that I had a kidney issue, acute kidney injury, while playing cricket. Because once I detected that I had blood in urine, and then when I went to a normal GP, that's when I realized that I had protein loss, and this was due to dehydration and excessive drinking of sports drink and NSAIDs.
Okay.
So this was the combination which for reason why I realized that I had acute kidney disease. So once I had the secondary hypertension, till I went, I took from CKD 1 to CKD 5, it was under control. But once I started on my dialysis and 2.5 years I did my transplant, my hypertension was, I was not able to control it. Irrespective of taking enormous amount of medication, I was not able to control, and one of the reasons to my kidney failure after transplant, graft was, they said, which is still an open situation, was uncontrollable hypertension, and which they said could be the reason why I had an aortic dissection while I was going through dialysis. So this is the question I would like to ask the cardiologist, because a lot of these questions were in our forum with the Kidney Warrior Foundation, that everybody, every time they go meet the doctors, their respective nephrologists and all that, they are not able to get down their hypertension down, even after increasing the dosage. So where, which I would like to know.
Yeah, we'll ask the while we go across the panel.
So this is one question I would like to ask the panel.
Sure.
So I could like to start the discussion from there.
Yeah, okay. We'll start with Dr. Senthil Kumar. Sir, in your experience on the practice lab, when you see heart patients coming to you, how common is hypertension first? We'll discuss how hypertension is a risk factor for kidney disease. How often do you see hypertension in cardiac patients? When do you see them?
Thank you, Dr. Balaji. Miginum Korainum Noisolum Nulor, Vanimidala Enne Mundru. It's a great honor and privilege to be a part of this panel discussion. I appreciate Kidney Warrior Foundation and all the involved people who have organized this excellent panel discussion. Thanks, Dr. Balaji. As you rightly told, risk factor, there are a few laymen here, so I will speak in the bilingual language. ஒரு மாரடைப்பு வருவதற்கான வாய்ப்புள்ள சூழ்நிலைகளை நம்ம ரிஸ்க் ஃபேக்டர்னு சொல்லுவோம். The risk factors for developing a heart disease, like from the cardiologist perspective, is hypertension, diabetes, smoking, alcohol, family history, obesity, sedentary lifestyle. I underline the statement, உடற்பயிற்சி இன்மை. Sedentary lifestyle is also a risk factor. Hyperlipidemia, postmenopause disease. Likewise, hypertension is one of the risk factor not only for developing a cardiac problem, for kidney disease also. So, symbol of love is, I think everyone will agree, the soft, tender organ, மென்மையான உறுப்பான ஹார்ட் வந்து பாதிப்பு ஏற்படுறது ஹைப்பர்டென்ஷன் அண்ட் டயபெட்டிஸ், ஸ்மோக்கிங், ஆல்கஹால். ஸோ அது மாதிரி இன் அவர் ப்ராக்டிஸ் யங் ஹார்ட் அட்டாக், யங் ரீனல் ஃபெயிலியர் பேஷண்ட்ஸ், ஒன் ஆஃப் த காமனஸ்ட் காசஸ் hypertension.
Dr. Muralidharan, when do you refer in your heart patients with hypertension? When do you think, in your experience, நீங்க எப்ப வந்து ஒரு nephrologist refer பண்ணுவீங்க as a preventive angle and creatinine ஜாஸ்தியான பிறகு? Your words on that.
Yeah, wonderful. Simple. Any patient we come across hypertension, like my friend, I didn't get your name, I'm sorry. Sumir. We'll answer that question first.
Yeah.
Like you said, grade stage 1 to stage 5, then it became uncontrolled. We use the term hypertension which goes to mild or moderate or severe, then resistant hypertension, refractory hypertension. The response to therapy is very good at the early stage. That's the number one. Later, when the CKD sets in, when the aorta, the vessel becomes stiffer, calcium comes in, then it's very difficult to manage it. So coming to your question, like I see in my outpatient, if I see a person with hypertension, we do a battery of tests, basic tests. We look at not only the hypertension part, but looking at hypertension mediated organ damage, HMOD. or really we call target organ damage. We look for how is his eyes, how is his brain, how is his kidney, how is his heart. Simple test. A simple after examination, basic urine examination, creatinine. The moment you find any abnormality, do not hesitate to involve your nephrology friend.
Correct.
A simple opinion, a proper counseling to the patient. Because what happens is, many of hypertensive patients, I like to quote from David Pickering, once he said, a known hypertensive is rarely symptomatic, whereas an unknown hypertensive a known hypertensive seldom asymptomatic, a unknown hypertensive rarely symptomatic. That is, there are people who have very high blood pressure walking around, like Georgie told in the morning, walking around the society without being aware that they are hypertensive. So hypertension is not there, like common mistake by many people, including doctors. I feel comfortable, I stop the medicine. I am okay, I am comfortable, because we do not treat hypertension for symptoms most of the time. Very rare, hypertension, urgency or emergency. Most of the time we treat to prevent the end organ damage. That will be a basic motive. So we need counseling. It goes a long way in motivating the patient and keep the BP under control and prevent end organ damage.
Yes, completely. We agree. It's both a combined approach of both the fields together to detect and prevent hypertension. Dr. Sita, how do you detect hypertension at an early stage? Can you just address the public about the awareness of regular blood pressure monitoring and how it helps in detecting kidney disease and the cutoff of blood pressure?
Good morning, everyone. I just thank everyone here for this opportunity. Generally, hypertension screening will be done at the general practitioner level. For people, anyone going to a clinic for some other issues. So if we start screening at that level, so we can pick up hypertension at an earlier phase. And also like screening the general public, like wherever possible for hypertension, like what they have done in the state, they are screening BP at home level, so that there can BP can be picked up at an early stage. And the target what we keep is like when it is more than like 130/80, we have to keep the patients on the track to see whether they need a medicine or lifestyle modification is enough. And we start medicine only when we are convinced that BP is high based upon the guidelines, and then we start the patients on medications or anything. So we have to screen the general public as a whole, what we are doing now. So it will help us to detect early. So what it means is like it will reduce the burden of both cardiovascular and renal disease, and also other end organ damage can be prevented if it is controlled at an early phase.
Yes. Next, we'll move on to Dr. Bhupati. We'll be discussing risk factors. Aதாவது heart problems kum kidney problems kum common risk factors என்னென்ன, அது எப்படி நம்ம treat பண்றது, common questions what general public will have. Dr. Bhupati, salt and hypertension, cardiology and the kidney perspective.
நம்ம உடம்புல இருக்க எல்லா ஆர்கனுமே இன்டர் கனெக்டட் தான். ஹார்ட், கிட்னி அப்படின்னு பார்க்கறத ஃபர்ஸ்ட் நம்ம விட்டுறணும். எல்லா ரிஸ்க் ஃபேக்டர்ஸுமே எல்லா ப்ராப்ளத்தையும் கொண்டு வரும். Majority of the risk factor that causes heart problem can cause kidney problem, and once kidney problem sets in, அது heart problem கொண்டு வரும். கிட்னி ப்ராப்ளம் வந்ததுக்கப்புறம் கிட்னி பேஷண்ட்ஸ் நிறைய பேர் கிட்னி ப்ராப்ளத்தினால இருக்கிறத விட ஹார்ட் ப்ராப்ளம் பக்கவாதம், அதனால் கார்டியோவாஸ்குலர் டிசீஸ்ன்னு சொல்லுவோம், அதில் தான் இறந்து போவாங்க அவங்க. Risk factors common for both the problems include diabetes, hypertension, uncontrolled hypertension especially, and poor dietary habits, and lack of exercise. Dyslipidemia மட்டும் கிட்னியில் அவ்வளோ ரோல் இருக்காது, அன்லைக் ஹார்ட் ப்ராப்ளம், கொலஸ்ட்ரால், கெட்ட கொலஸ்ட்ரால் ப்ராப்ளம். ஒன்ஸ் ஹார்ட் ப்ராப்ளம் வந்துருச்சு, ஹார்ட் பம்பிங் கம்மியாயிடுச்சு அப்படின்னா அது ஃபர்தராக பிளட் கிட்னி கொண்டு போய் இந்த கிட்னிக்குள்ளே ப்ராப்ளம் கொண்டு வரலாம். கம்மிங் டு யுவர் கொஸ்டின், salt வந்து டெஃபினட்டாக பிளேஸ் மேஜர் ரோல் இன் கிரியேட்டிங் ஹைப்பர்டென்ஷன், இன் மெயின்டைனிங் ஹைப்பர்டென்ஷன். We strongly recommend to have DASH diet advice to stop hypertension. அதில் ஃபர்ஸ்ட் பாயிண்ட்டு சால்ட் கம்மியாக சாப்பிடணும், less than 4 கிராம். அதுக்கு அளந்து சாப்பிட முடியாது நம்ம. இன் ஜென்ரல் இதுக்கு முன்னாடி எவ்வளோ உப்பு சாப்பிட்டு இருந்தோமோ அப்படியே 2 ஸ்பூன் உப்பு போட்டு ஆவரேஜாக எல்லாரும் போகிறோம், அதை பாதி ஸ்பூன் ஆக்கிடணும். That is a major thing that will have a significant impact. Salt-rich foods like அப்பளம், ஊறுகாய், பிஸ்கட்டு, இந்த மேரிகோல்டு பிஸ்கட், அதெல்லாம் உப்பு கொஞ்சம் அதிகமாக இருக்கும், அதில் உப்பு வச்சு பிஸ்கட்லாம் வருது, அதெல்லாம் நம்ம அவாய்ட் பண்ணிக்கிறது ரொம்ப நல்லது.
Sure, sir. Next, we'll move on to Dr. Muralidharan. obesity, sir, and hypertension. Definitely, obesity is becoming a epidemic which already is there in most of us. Different guidelines are there from the Asian and the European and the Indian data. So, obesity as a risk factor for hypertension and also as a kidney disease.
Yeah, it's more from a cardiac perspective.
Yes, sir. Yes.
We prefer people to have ideal body weight for every health. நம்மளோட ஒரு காமன் ப்ராப்ளமே யாரை பார்த்தா எனக்கு எலக்ட்ரிக் அடிப்பாங்க, ஏதாவது ஒரு பெரிய மோசமான சகுனம் மாதிரி. அது ஒரு வே ஆஃப் ஸ்டார்டிங் கான்வர்சேஷன் மாதிரி. சினிமா திரையிலே பாதி வந்து என்ன சினிமா பார்த்தீங்களான்னு கேட்பாங்க அந்த மாதிரி. ஸோ வாட் ஐ யூஸ் டு சே இஸ் if someone says எனக்கு எலக்ட்ரிக், be proud that you are maintaining.
Yes.
You are becoming malnourished or your BMI goes below 20, 21, அந்த மாதிரி இருந்தால் தான் you could worry. So that is number one, because the moment you become obese, we have several obesities, like central obesity, adipose tissue, many things. Everything takes you towards metabolic syndrome, wherein everything comes in. Your triglyceride goes up, your insulin resistance goes up, you become pro-diabetic or pre-diabetic or diabetic, your hypertension sets in, ready to affect both the organs, heart and kidney.
Correct.
That's a basic thing. So, maintaining ideal body weight is going a long way. Like Bobai சொன்ன மாதிரி, not only salt, a low salt diet, weight will also come down. Because low salt diet, the food will be little less palatable. Okay, so it may not be going for eating binge and all. So what I'm trying to stress is maintain adequate salt and a proper diet goes in a long way. Like கொஞ்சம் பேசினா மருந்தன வேண்டாம் யாக்கைக்கு அருந்தியது அற்றது போற்றி விடும் வள்ளுவர் எப்போ சொன்னது. So food going to be the major ingredient to maintain.
Yes, sir. Nicely said. Dr. Senthil, அடுத்தது சில பேஷண்ட் வந்து கேட்டிருப்பாங்க உங்க ப்ராக்டிஸ்ல வந்து, என் வீட்டில் வந்து அம்மா அப்பாவுக்கு பிளட் ப்ரெஷர் இருக்கு, ஹார்ட் ப்ராப்ளம் இருக்கு, கிட்னி ப்ராப்ளம் இருக்கு, எனக்கும் அது வருமா அப்படி ஒரு கேள்விக்கு நம்ம how do we answer the public, how do we answer and what measures do we take?
நல்ல கேள்விங்க டாக்டர் பாலாஜி. இப்போ ஒன் ஆஃப் த ரிஸ்க் ஃபேக்டர் வந்து ஃபேமிலி ஹிஸ்ட்ரி. ஸோ தேர் ஆர் மாடிஃபைபிள் ரிஸ்க் ஃபேக்டர், நான் மாடிஃபைபிள் ரிஸ்க் ஃபேக்டர். மாடிஃபைபிள் ரிஸ்க் ஃபேக்டர்னா பிபியை கண்ட்ரோல் பண்ணலாம், சர்க்கரையை கண்ட்ரோல் பண்ணலாம், கொழுப்பு சத்து எல்டிஎல் கண்ட்ரோல் பண்ணலாம். நான் மாடிஃபைபிள் ரிஸ்க் ஃபேக்டர் ஃபேமிலி ஹிஸ்டரி. ஒரு ஃபாதர் மதரை மாற்ற முடியாது, ஏஜை மாற்ற முடியாது, மேல் பர்சன் இஸ் ரிஸ்க் ஃபேக்டர். ஸோ அது மாதிரி இப்போ டாக்டர் பாலாஜி சொன்ன மாதிரி ஒரு பேஷண்ட் வராரு ஃபேமிலி ஹிஸ்டரி அப்படின்னு சொல்லும்போது, there are two things irrespective of whether the doctor is a nephrologist, cardiologist, ophthalmologist, gynecologist, whatever may be the field. There are 2 to 3 things duty of a doctor. One is proper early diagnosis. Second is treatment. Third is, as Dr. Balaji rightly pointed out, preventive aspect. இது வந்து 3 டியூட்டி. இதுல வந்து நம்ம சப்டிவிஷனை பிரிச்சுட்டா டிசீஸ் வேற, இவெண்ட் வேற. டிசீஸ் இஸ் த ரிஸ்க் ஃபேக்டர், ஹைப்பர்டென்ஷன். event is a heart attack or a renal failure. Disease control panna, event control panna. So it is our duty to create awareness in Trichy. So the World Hypertension Day, World Heart Day, World Heart Day is the last Sunday of September 27th. That last Sunday, depending upon that year, we commemorate the World Heart Day to create awareness about heart disease, to prevent heart problems, to prevent a heart attack. Likewise, we have a World Hypertension Day, May 17th. So in the Darada in Trichy, we had a unique opportunity. So I represented the Trichy and we requested the jail DAG. Jail prisoners, we got a special permission on May 17th, World Hypertension Day, to create awareness about hypertension, to proper treatment, to prevent end organ damage. So ஒரு mnemonic ஒரு 7-8 yes ஆங்கில வார்த்தை எஸ் வச்சு சொல்றேன். ஸோ ரிஸ்க் ஃபேக்டர் அண்ட் ஹவு டு ப்ரொடெக்ட். எஸ் சால்ட் ரெஸ்ட்ரிக்ஷன். ரெண்டாவது சுகரை ரெஸ்ட்ரிக்ட் பண்ணா பிபி கண்ட்ரோல் ஆகும். சால்ட் ரெஸ்ட்ரிக்ட் பண்ணா பிபி சுகர் கண்ட்ரோல் ஆகும், பிபி கண்ட்ரோல். மூணாவது ஸ்ட்ரெஸ் ஃப்ரீயா இருங்க. நாலாவது ஸ்மோக்கிங் அவாய்ட் பண்ணுங்க, அடுத்த எஸ். அஞ்சாவது எஸ் ஸ்பிரிட் இன் த ஃபார்ம் ஆஃப் ஆல்கஹால் அவாய்ட் பண்ணுங்க. ஆறாவது செடென்டரி லைஃப் ஸ்டைலை அவாய்ட் பண்ணுங்க, நல்ல எக்ஸசைஸ் பண்ணுங்க. ஏழாவது இப்போதைக்கு இருக்கிற சூழ்நிலையில் ஸ்லீப் டெப்ரிவேஷன். ஸோ ஸ்லீப், நல்ல தூக்கம், நல்ல உணவு, நல்ல உறக்கம் இருந்துச்சுன்னா உங்களோட இதயத்தையும் சிறுநீரத்தையும் சூப்பராக பாதுகாத்துக்கலாம்.
எஸ் சார். ஸோ ஆஸ் செந்தில் சார் சொன்ன மாதிரி ஸ்மோக்கிங் அண்ட்
it increases both sugar and BP. ஸோ இப்போ இருக்கிற டைம் பீரியடில் பார்த்தா இப்போ நிறைய ஐடி பீப்புள் கம்மி. ஸோ அவங்க வென் ரிஸ்க் ஃபேக்டர்ஸ் ஜாஸ்தி ஆகும்போது கார்டியோவாஸ்குலர் ரிஸ்க் அண்ட் ரீனல் ரிஸ்க் எல்லாமே ஜாஸ்தி ஆகுது. ஸோ when we reduce the stress, risk factor modify பண்ண முடியும். risk factor modify பண்ணா we can reduce the event rate.
ஷுவர். எந்த லைஃப்ல தான் இப்போ ஸ்ட்ரெஸ் இல்லை, வாழறதே ஸ்ட்ரெஸ்ஸும்பாங்க நிறைய பேர். எனிவே we have to live with stress, we will learn to control blood pressure. Dr. Bhupati sir, a patient comes to the OPD, first time in his life he is checked, அவங்க blood pressure பார்த்துருக்காங்க, value is 150/90. அவர் கேட்குறாரு, இப்போதான் எனக்கு இருக்கீங்க, நான் இப்போவே மருந்து எடுக்கணுமா? வாட் இஸ் யுவர்
வெரி குட் கொஸ்டின். ஆக்சுவலி ஒரு ரீடிங் வச்சு என்னைக்கு போகக்கூடாது. ஃபார் ஒரு பேஷண்ட் ஃபர்ஸ்ட் ரீடிங் இப்போ 180-100 மேலே இருக்குன்னா இட்ஸ் அன்லைக்லி டு பி ராங். 150-90 தான் இருக்குன்னா இட் மே பி ராங். அவர் கொஞ்சம் வேகமாக நடந்து படி ஏறி 2-3 மாடி ஏறி வந்தால் கூட அந்த மாதிரி இருக்கலாம். ஸோ கொஞ்சம் 10 நிமிஷம் உட்கார வச்சுட்டு பிபி பார்க்கறதுக்கு ஒரு வரைமுறைகள் இருக்குது. உட்காந்து கால் தரையில் இருக்கணும், பேக் சப்போர்ட் இருக்கணும், கை சப்போர்ட் இருக்கணும், 5 நிமிஷம் சேரில் உட்காந்துக்கணும், அதுக்கப்புறம் தான் பிபி பார்க்கணும். எவ்வளோ இருக்குன்னு தெரியும், அதை பேஸ் பண்ணி நம்ம ட்ரீட்மெண்ட் ஆரம்பிச்சிக்கலாம். ஸோ ஒரு ரீடிங்கை வச்சு மட்டும் யூஸ்வலாக நாங்கள் தெரப்பி ஆரம்பிக்க மாட்டோம். ஒருவேளை கன்ஃபார்ம் ஆனாலும் if this is only pre-hypertension, stage 1 hypertension, we'll give the option of lifestyle modification first. Nothing is going to happen acutely. எதுவுமே இமீடியட் எதுவும் நடக்காது, எல்லாமே chronic diseases. அவங்க டயட் கண்ட்ரோலாக வச்சுக்கிட்டு உப்பு கம்மியாக சாப்பிட்டுட்டு வெயிட்டை குறைச்சாங்கன்னா அப்படின்னா அதுவே ஒரு 5 to 10 millimeter பிபியை ரெடியூஸ் பண்ணுவோம். அவங்க பிபி இப்போதைக்கு 135 தான் இருக்குது அப்படின்னா no need to put them on drugs. லைஃப் ஸ்டைல் மாடிஃபிகேஷன்லேயே கொஞ்சம் குறைச்சிட முடியும்.
கரெக்ட் சார். ஸோ இன்ஃபேக்ட் சார் சொன்ன மாதிரி there is a new method, new இல்லை, it's been there, but for the awareness of the public, ambulatory blood pressure monitor, அதாவது 24 hours பிபியை மானிட்டர் பண்ணி lot of definitions are there. அதில் வச்சு we can diagnose hypertension early, treat them and prevent them from complications. Next, Dr. Muralidharan sir, the common medications what is used to treat hypertension, can you just tell them about in few words to the public?
I'll put this way. BP வந்து பேசிக்காக it's a combination of two things, are a product of what the heart pumps, cardiac output எவ்வளோ வெளியே போகிறது, இன்னொன்று சிஸ்டமிக் வாஸ்குலரைசேஷன், அதாவது நம்ம ரத்த குழாய்கள் எந்த அளவு ரெசிஸ்ட் பண்ணுது. ட்ரீட்மெண்ட் வில் பி எய்ம்ட் அட் எய்தர் கண்ட்ரோலிங் த கார்டியக் ஐயா இல்லை கரெக்டாக இருக்குது, மெயின்டைன் எஸ்பிஆர்ஐ. மோஸ்ட் ஆஃப் டைம் இந்த பெர்விலேஷன் குறைக்கிறது தான் முக்கியமான ட்ரீட்மெண்ட்டாக இருக்கும், நம்பர் 1. பட் இது வந்து பேசிக் ஃபிசிக்ஸ்னாக்கா அதுக்கு பின்னாடி பெத்தோஃபிசியாலஜி ஆர் பயாலஜின்னு பார்க்கும்போது வேரியஸ் ஃபேக்டர்ஸ், அந்த பேஷண்ட்டோட ஏஜ் என்ன, அவருடைய கோமார்பிடிட்டி கண்டிஷன் என்ன, ஸ்மோக்கரா, ஆஸ்மேட்டிக்கா, டயபெட்டிஸ் இருக்கா, இந்த ரெனின் ஆஞ்சியோடென்சின் ஆல்டோஸ்டெரான் சிஸ்டம் இன்ஹிபிஷன் சொல்லுவோம். காமன் நம்ம பார்க்குற இந்த கேப்டப் கால்சியம் பிளாக்கர்னு சொல்லுவோம். அம்லோடிபின், நிஃபடபின் ஒரு குரூப். டயூரிட்டிக், யூரின் கொஞ்சம் போகிறதுல பல டைப் இருக்குது, லூப் டயூரிட்டிக், தயசைட் டயூரிட்டிக், அந்த மாதிரி. ஸோ வி see the patient condition, இதெல்லாம் காமன் ட்ரக் being used nowadays, and you try combination also. இப்போ கரண்ட் திங்கிங் வந்து 2 ட்ரக் அட் லோயர் டோஸ் காம்பினேஷன் ஆர் 3 ட்ரக் கூட சில டைம் யூஸ் பண்ணுறோம் டு மெயின்டைன் இட். ஸோ few pills are freely available. Only biggest message I would like to convey is most of the BP medicine are very cheap. I used to tell my patient, நம்ம ஹார்ட் ஹெல்த்தை ப்ரொடெக்ட் பண்ணுறது 2 விஷயங்கள், செலவு குறைக்கிற விஷயம் ஸ்மோக்கிங் நிறுத்துறது, செலவு கம்மியான விஷயம் பிபி கண்ட்ரோல் பண்ணுறது. வேறு இது மூவிங் டு டயபெட்டிஸ், கொலஸ்ட்ரால், அப்புறம் ஆஞ்சியோபிளாஸ்டி பண்ணேன், அது தப்பான மருத்துவங்க சொல்லப்போனால். அந்த ஸ்டேஜுக்கு போகாமல் ஆரம்ப ஸ்டேஜில் பிபி கண்ட்ரோல் பண்ணுறது ரொம்ப ஈஸி. நான் சொன்ன பல மருந்துகள் வந்து லெஸ் தென் 2 rupees 5 rupees கவர்மெண்ட்டில் இன்னும் கம்மியாக கிடைக்குது, ஃப்ரீயாகவும் கிடைக்குது. ஸோ மோர் தென் த நம்பரிங் வி ஆர் இன் அ வெரி 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 ஃபார்ச்சுனேட் சிச்சுவேஷன். அஃபோர்டபுள் மெடிசன் அவைலபிள் ஃப்ரீலி, கவர்மெண்ட் ஹாஸ்பிட்டல் ஆர் லோ காஸ்ட் ஆல்சோ. Please you take care of the blood pressure in kidney disease with one BP medicine. எப்பவுமே பார்த்தீங்கன்னா நீங்க you would have seen kidney patients 3-4 மருந்து, sometimes 4-5. அதுவும் அந்த டயாலிசிஸ்ல வந்துட்டாங்கன்னா the number of BP medicines இவ்வளவு பெருசா இருக்கும் அவங்களுக்கு. So it is all prevention is better than cure. அதுதான் நாங்கெல்லாம் திருப்பி உங்களுக்கு சொல்ல வரோம். We would also like to involve our audience. Audienceல இருக்கிறவங்களுக்கு ஏதாவது questions கேட்கணும்னா panelists are ready to answer.
We will go with 1 or 2 questions from the audience, please.
I'm Dr. Saraswati, an ophthalmologist. Whenever we come across patients with kidney problems, we are hesitant to give drops. Most of our medications are drops. As NI said is, we are hesitant to give because it might have an impact on the systemic thing. So how real is the problem? Can we freely prescribe medications NSAIDs whenever it is required for the...
See, the topical NSAIDs have shown not to have much of absorption into the systemic circulation.
Okay.
So topical NSAIDs, we in fact in our fitness letter we write topical NSAIDs you can definitely use, it's not a problem.
That's great. Another question is like, we say it's not the blood pressure that is more important. So is there any cutoff as to how much of diastolic or how much of systolic? It can be 220 or something and still it is not a problem. Is there any valid cutoff when we think about these patients?
No, that is very simple. Lot of studies. Diastolic BP. Now it is the systolic BP crossing 140, we do not want. Diastolic BP crossing 90, we don't want. 130 to 139, we say high normal. Same way, 80 to 89, we say high normal. Suppose my patient having 120, 80 BP, comfortable, control, fine. The moment it crosses 140, 90, I want to intervene. Like Bhupati said, it can be a lifestyle modification, follow-up, or sometimes upfront medication, depending on the situation. But 140, 90. And isolated systolic hypertension is one of the commonest thing and commonest problem. Now, isolated diastolic hypertension is little less common, and it's an important point. 140, 90.
Doc, I have a question. Because as a patient, எங்களுக்கு வந்து இந்த ப்ராப்ளம் இருக்கும். நார்மலாக நாங்கள் பிபி செக் பண்ணும்போது ஒரு பார்த்தா நம்ம வந்து ஆட்டோமேட்டட் மானிட்டரில் பார்க்குறோம், கொஞ்சம் ஹையாக இருக்கும். பிட்வீன் அந்த ரீடிங்க்கும் நெக்ஸ்ட் ரீடிங்க்கும் நம்ம சம்டைம்ஸ் சில பேர் சொல்லுவாங்க 5 மினிட்ஸ் சொல்லுவாங்க, சில டைம் நம்ம வந்து அந்த டென்ஷனில் பார்க்கணுமா கொஞ்சம் சடனாக ஸ்பைக் ஆகிருக்குன்னு இருக்கும். நம்ம மாத்திரை சாப்பிட்ருப்போம், ஆனாலும் கொஞ்சம் ஹையாக இருக்கும். ஸோ அதனால் வாட் இஸ் த டைம் கேப் பிட்வீன் ஃபர்ஸ்ட் ரீடிங் அண்ட் செகண்ட் ரீடிங் அண்ட் ஹவு ஆஃபன்? இப்போ நான்லாம் பேரனாய்டாக இருப்பேன், ஏன்னா நான் வந்து பிபி இதனால செக் பண்ணிகிட்டே இருப்பேன். சில வாட்டி எனக்கு பிபி குறைஞ்ச மாதிரி ஒரு ஃபீலிங் இருக்கும், கொஞ்சம் லோவாக இருக்குமா, பிபி சாப்பிடணுமா, டேப்லெட் சாப்பிடணுமா வேணாம். பிகாஸ் டயாலிசிஸில் வந்து பிபி குறைஞ்சிருச்சுன்னா டயாலிசிஸ் வந்து டேஞ்சரஸாக இருக்கும். ஸோ அதனால் அந்த டைம்லேயே நாம் டயாலிசிஸ் போகிறதுக்கு முன்னாடி மெடிக்கேஷன் சாப்பிடக்கூடாது இதெல்லாம் சொல்லுவோம். 160, 170 வச்சுக்கணும்னு சொல்லுவாங்க டயாலிசிஸ்க்கு, பிளட் சர்க்குலேஷனுக்கு. பட் டிரான்ஸ்பிளான்ட்க்கு அப்புறம் பார்க்கும்போது இட் இஸ் அ வேரியேஷன் இருக்கு. ஈவன் ஆஃப்டர் டேக்கிங் மெடிக்கேஷன் சம் டேஸ் இட் இஸ் நார்மல், சம் டேஸ் அந்த ஸ்பைக் ஆகுது. ஸோ ஹவு வாட் இஸ் த டைம் கேப் ஷுட் ஐ சி? நார்மலி வெல்சே இதே ஒரே டைமில் தான் பார்க்கணும்னு, பட் அந்த ஒரு கான்ஸ்டன்ட் நம்ம வந்து இந்த பார்ப்போம் 140 காமிக்குது, 92, 93 காமிக்குது, சரி திருப்பி செக் பண்ணலாமா? வாட் இஸ் த கேப் சொல்றீங்களா? எனிபடி கேன் ஆன்சர்.
See, good question. கொஞ்சம் கைட்லைன் வெளியே போகிறோம். இப்போ நம்ம புரிஞ்சுக்கிறதுக்கு லைக் டாக்டர் பூபி சொல்ல கைட்லைன் எல்லாமே என்ன சொல்லணும்னா, அப்படியே ஃப்ரீ கரெக்டாக உட்காந்துக்கிட்டு கால் தரையில் பட்டு கை வச்சுக்கிட்டு ரிலாக்ஸாக ஒரு 5 நிமிஷம் கழித்து கம்ப்ளீட் ரெஸ்ட்டில், சிகரெட் பிடிச்சிடக்கூடாது 15 மினிட்ஸ், காஃபி எடுத்துடக்கூடாது 30 to 40 மினிட்ஸ். நம்ம வாழ்க்கையில் அப்படி இருக்கிறது ஒரு நாளில் பார்த்தா மேபி 1 to 2 hours. காலைல எந்திரிச்சாலே ப்ரெஷர் தான். ஸோ ஐ ஆல்வேஸ் கொஸ்டின் திஸ். இந்த மாதிரி நான் நார்மலாக இருக்கும்போது இருக்கிற பிபி உண்மையா, இல்லை நான் ஆஃபீஸில் பிஸியாக இருக்கும்போது எடுக்கிற பிபி உண்மையா? ஏன்னா ஒரு நாள் 8 மணி நேரம் ஒர்க் பண்ணுறேன், அப்போ ஐபிபி இருப்பேன். வி யூஸ் அ டேர்ம் நவ் கால் மாஸ்டர் ஹைப்பர்டென்ஷன். இந்த மாதிரி உட்கார வச்சு பார்த்து நார்மலாக அனுப்பிடுறோம், அவங்க அப்புறம் பார்த்தா மாஸ்டர் ஹைப்பர்டென்ஷன் கண்டாமல் அன்கண்ட்ரோல் தான். Other thing is nocturnal hypertension. So I, as a cardiologist, though it doesn't come into the guideline, so I am not forcing it. I believe on ambulatory BP. 24 hours ambulatory BP tells me what is the blood. And the ஒரு நிமிஷம் நான் கண்ட்ரோல் பண்ண. ரெண்டாவது நீங்கள் சொன்னீங்களே, some 90 when you are very busy, 20-75. Because we have very clear evidence, nocturnal hypertension, நல்லா தூங்கும்போது BP டிப் ஆகும். And the non-dippers, they fare very badly. Hope I have answered this question.
Yeah, thank you.
Sir, with concurrence of Dr. Murali sir, ஒரு 2 பாயிண்ட் மட்டும் ஆட் பண்ணிடுறேன். Dr. Murali sir சொல்லும்போது he was speaking about masked hypertension. There is another terminology called white coat hypertension. The patient comes inside the doctor's chamber. கரெக்டாக டாக்டரை பார்த்தோன்னா பிபி ஜாஸ்தி ஆகும். That's white coat hypertension. Likewise, non-dippers பற்றி we are speaking about heart attack, myocardial infarction and renal failure. Non-dippers are more prone for developing stroke. All are connected problems: heart attack, stroke and renal failure.
Yeah, I thought there was another question from somebody. Yeah, last question, yes.
I'm here, ma'am. See, he is an active sports person, still he develops CKD, right? Yeah. There are number of factors which young adults and young athletes do develop CKD. Is that any specific thing which we have to look for? Any sports things we have to avoid?
See, the athlete-related kidney disease itself is a topic what we have to discuss. See, the chronic, it does not lead on to a long-standing kidney damage. See, mostly what we do is, these nowadays is the younger generation, they are very interested in gym, building up the body and all. Two things what we see commonly, they prescribe, the workout gym instructor, they prescribe creatine powder. If they prescribe creatine வந்து உடம்புல creatinine convert ஆகும். In fact, that's what we measure in the blood as creatinine. So we'll see very muscular people who are going to the gym, their creatinine maybe 1.5, 1.4. You ask them this question, are you taking supplements? Most often they say yes, and the answer is the creatine. The second thing வந்து என்ன பார்க்கணும்னா hydration. So if they are unaccustomed exercise without any proper training, if they do, it will lead on to kidney disease. Dehydration will lead on to acute kidney injury. ரெண்டாவது மசில் ஃபைபர்ஸ் டேமேஜ் ஆச்சுன்னா, அன்அக்கஸ்டம்ட் ஒர்க் பண்ணோம்னா, undue exertion with dehydration, மசில் ஃபைபர்ஸ் will get damaged. மசில் ஃபைபர்ஸ் டேமேஜ் ஆச்சுன்னா அந்த பிக்மெண்ட் கிட்னி உள்ள வந்து பிளாக் ஆகும். So that will lead on to another disease called rhabdomyolysis. All these are acute problems. It will definitely reverse on the long term. Of course, our sports person, if he's been maintaining all his health condition normally with no diabetes, hypertension, kidney disease கண்டிப்பா வரக்கூடாது. It's a preventable disease. Yeah.
Doc, last question, which is a controversial question. I have been reading and also been seeing a lot of cases where post-COVID vaccination, there are cases of people having heart attacks and young adults. I just want to know from your experience in India especially, because it's abroad there's a lot of discussion happening, but in our experience in our practice, what are the situation of post-COVID vaccination, people having heart attacks in a young, healthy adult?
I'll take yes, Balaji. There are three things regarding COVID, as he rightly pointed out. Slightly gray zone question, controversial. There are three things. First is during the course of the disease, irrespective of whether it's a renal failure, COVID, or heart attack, during the course of the disease. Second thing is post sequelae of that disease. Third is regarding vaccination. During the course of the disease, incidence of heart attack or renal failure is relatively less. Number two is post-sequelae to COVID, we have found that hypercoagulable state, that blockage occurring in young patients, blockage occurring in patients without risk factors, that is post-sequelae, was seen, were seen, not now. Third is regarding vaccination. It should not send a false message. Regarding vaccination, there are millions of people who have been protected against this pandemic. The gravity of the severity of the disease, even if the person who has been vaccinated, even if the person had a COVID, the severity of the disease has been decreased. The highlighted point is there are few people who had this problem which is being highlighted. So it's not sent a false message that generalize, you should not generalize the statement that COVID vaccination causes young heart attack, young stroke or renal failure, or so that every drug, irrespective of whether it's a COVID vaccine or any drug, will have its side effect. You have to weigh the risk-benefit ratio. When the benefit is more, you have to give the drug. When the risk is more, you should not give the drug for that person, for that disease. I think Dr. Murali will add.
Thank you. So I think for want of time, we'll conclude this session. So hypertension is a very important non-communicable disease, silent killer. BP ஒழுங்கா பார்த்தா definitely we can prevent chronic kidney disease. So அது வந்து எல்லாருக்கும் நம்மளுக்கு தெரியணும். The second point is BP இருந்தா கூட அது ஒழுங்கா கண்ட்ரோல் பண்ணா kidney disease will not progress. CKD stage 1, 2 இருக்கிறவங்க BP ஒழுங்கா கண்ட்ரோல்ல வச்சுக்கங்க. 140/90 is not the cutoff in blood pressure for CKD. In fact, it's little lesser. Protein இருக்கும்போது it even comes down to 120/85. So blood pressure detection is important, control is important. So thank you once again for having this discussion. It was a pleasure, sir. Thank you.
Thank you, Dr. Balaji. Can we have Dr. Balaji hand over a small token of appreciation to our panelists?
Thank you, sir. Thank you.
Without further delay, we'll move on to our next session, and again, it's another interesting session because the next killer, which is diabetic, we're going to have the diabetologist join us on the dais. But before that, I'm going to welcome our moderator. May I request you to please put your hands together for a perfect nephrologist from Triple Hospital, Dr. Our diabetologist to join us on stage is Dr. Kannan, Dr. Lavin. For being seated here, this might be very interesting information that when you're ophthalmologist also plays a very important role in picking up kidney disease. And to join us on stage, we request our ophthalmologist, Dr. Saraswati and Dr. Deepak, to please take their seats on the panel.
Dr. Suresh has not come. Thank you, Marianne, and thank you for organizing this very important session and for the public as well as others present here. So good morning to one and all in kidney disease. Diabetes is the most common cause of chronic kidney disease in India as well as the world. The importance of early screening for kidney disease in diabetes cannot be overemphasized. So what's the eye doing here? So, the patient always I tell them, the eye can be a window to what's happening in the kidney, especially in diabetes. So with this, I welcome our august and esteemed panelists. So without much ado, we'll get into the session. So my first question is to Dr. Kannan. Sir, at what stage of diabetes do people come to see you? Generally, do you feel it's too late by the time they get their diagnosis of diabetes, and have they already developed the complications related to diabetes?
I thank this one Kidney Warrior Foundation for giving a great opportunity. See, usually if you see the diabetes classification, there are various steps, but I'm going to talk only on the simple thing. That is, one diabetic population belong to as pro-diabetes, that is with family history. A certain population with the pre-diabetes, those who have the impaired, that is high normal fasting sugar and also the high normal branded sugar. And other diabetes populations, frank diabetes, that is confirmed diabetes, HbA1c more than 7 and fasting sugar more than 130 and branded sugar more than 200. In our clinical scenario, if you see the population who are attending to our clinic, in the pre-diabetes itself, they have to come, but they are coming only after 6 months or 1 year, after having any symptoms only, because no patient will be coming to the doctor to check their body. When they have any clinical abnormalities, like if they have any infection, if they have any urine infection, if they have any numbness of feet, if they have any burning sensation, if they have any infection over the penis or infection over the vagina, then only they will be coming and we will be screening the population. If you see the diabetes scenario in our India, recently it has been confounded by our ICM or INDAP data. It's very, very alarming and pathetic also. See, previously it was around only 77 million, but recently they found 103 million population in India are suffering from diabetes. Among that, 130 millions are pre-diabetes. If you see the total diabetes dysglycemia, almost 330 populations or 230 populations suffering from. This is a pathetic scenario. So among these populations, we want to assess, access and act early. That is, screening the patient early, diagnosing the patient early, and accordingly we have to treat the patient. This is the thing we want to implicate, and we want to advise the patient. So awareness and education are the important tool in our clinical practice to focus on the patient benefit, and also we want to render the good quality of life and outcome for them.
Thank you, sir. So with that, what sir said was that there are namukku patients varanga OP la, and what we see nowadays is they may be just 40, they may be 45 years old, and creatinine is around 6 and 7, and with a whole lot of proteinuria in the urine. So one of the questions are like, Doctor, in age ala. So Dr. Lavanya, do you feel that the population is getting younger and younger?
Yes, obviously, because of maybe younger age group are getting more
non-communicable disease like diabetes and hypertension because of sedentary lifestyle and unhealthy eating habits. So for them, like more than 35 years of age, we have to screen for diabetes, hypertension and all. So key is early detection and early detection of diabetes and preventing the complications related to diabetes like retinopathy, nephropathy and peripheral neuropathy, major macrovascular complications like CAD and other stroke and all.
So macrovascular, what do you mean by macrovascular complications? We have
like cardiovascular disease, stroke, all those things.
Okay. So as Kannan sir was saying, they come only when they have symptoms. So what are the early detection signs of diabetes and what are the early detection signs of diabetes with kidney disease?
Like we have to, first we have to tell the patient why we are screening, otherwise they will not investigate. So we have to explain why we are screening. So first thing is we have to see microalbuminuria. And then we have to see creatinine, EGFR, the urea, and for eye also, fundus examination is also very important because early stages they will not have any symptoms. So they will not have reduced urine output or any edema and all. So we have to screen.
So as ma'am rightly said,
hypertension screening is also very important.
Yeah. So as ma'am rightly said, anybody who comes even for the first time with diabetes, especially type 2 diabetes, it's very important to screen the kidney. And there are two simple tests you can do to screen the kidney. One is the serum creatinine and other is a simple urine analysis which will give us information on protein leak and any other things happening with the kidney. And once we detect it early, it's actually fairly easy to prevent the progression of kidney disease. Coming back to Dr. Kannan, what are the first set of tests ஒரு patient வரைச்ச உங்க கிளினிக்கு diabetes, first time diagnosed with diabetes, what are the general tests that you recommend to screen for diabetes as well as its complications?
யூஸ்வலாக நம்ம கிளினிக்கில் வந்து ஒரு டயபெட்டிக் பேஷண்ட் வந்தாங்கன்னா we used to advocate the all basic protocols regarding the diabetic profile, right from the blood counts. Then we advocate the patient to go for urea and creatinine regarding with the kidney function. Then we advocate the patient go for the lipid profile, all the cholesterol, normal cholesterol, bad cholesterol, good cholesterol and all. And also important with the thyroid function because there is a link between the thyroid function as well as the diabetes. It's interlinked. And also we rule out the CRP also because you know that diabetes is an inflammatory state, is a cardiovascular risk equivalent disease, and therefore we want to rule out whether they have any vascular inflammation in the form of C-reactive protein. In some cases we are supposed to see the urine creatinine clearance also and urine complex. So these are the basic methodology, but if you see, like Lavanya was telling you, microalbuminuria is one of the earliest screening tool, but in diabetic patients, if you see, there are two classical forms of kidney disease. One is CKD, another is DKD, that is diabetic kidney disease. There are major trials have been clearly concluded. UKPD trial is one of the important landmark trials among the diabetic population. They found among the diabetic patients, if you see the protein leak, microalbuminuria percentage was very less, only 36%. Remaining more than 60%, that doesn't have any finding regarding with the microalbuminuria. So don't rush behind the microalbuminuria. Previously, you're supposed to do urea and creatinine. Previously, you're supposed to do other evaluation based. Simply testing one protocol with the microalbuminuria doesn't show the impact and bottom of the kidney disease. That is the thing I want to inform in this August audience and before the public also. So, microalbuminuria matto pata pattadu. Then we have to see the urea and creatinine. Some patients வந்து the protein leak இருக்காது. Earliest manifestation like stage 1, stage 0, stage 1 வந்து that doesn't have microalbuminuria because less than 30 is normal. Microalbumin less than 30 is normal. So 0 to 30 ன்றது எடுத்தோனே வராது. Early அந்த stage 0, stage 1லே வந்து patient capture பண்ணி அப்பவே intervene பண்ணி அப்பவே we want to implement the DASH diet, appropriate physical activity, appropriate dietary manifestation. We want to support them only because all the diabetic patients should become a diabetologist. That is so-called as diabetic self-management education and support, DSMES. We want to educate them properly. We want to categorize them properly and want to implement them properly accordingly to prevent the complications.
So, you DASH diet and சொல்லுங்க. What is the utility of a DASH diet in diabetes and what is it actually?
DASH diet nothing but the salt restricted diet, that is dietary approach to stop the hypertension. So we want actually all the diets should be always balanced. There are no specific diets. But in diabetic population with hypertension, with impairment of the kidney disease, so this to be focused specially as a DASH diet, that is salt restriction. Already Dr. Abraham was telling 4 grams per day. It's very difficult to calculate the 4 grams. That is, if you take 2 teaspoons of salt, make it as half teaspoon. That is a DASH diet. Increase the physical activity. That is important. These are the both cornerstones, both the pillars in the management of diabetes along with the kidney disease. Salt நம்மளுடைய பெரிய எதிரி. நம்ம ரொம்ப நாள் வாழ வேணும்னு நினைச்சா சால்ட் வந்து கம்மி பண்ணி சாப்பிடணும். ஸோ எவனுக்கு நம்ம சால்ட் கம்மி பண்ணி சாப்பிடுமோ அவனுக்கு அவ்வளோ நம்ம நீண்ட ஆயுள் நல்லபடியாக இருப்போம், எந்த காம்ப்ளிகேஷன் இல்லாமல். ஸோ we love carbs, we love salt and we love fat. Indians are more predominant for that. And that's the reason complication also loves us. We want to come against that.
So I think one of the excellent ways of cutting down salt is actually getting rid of processed food, and which has a huge amount of salt and other bad stuff both for diabetes as well as the kidney. So, and I'm glad Dr. Kannan brought this up, that not every diabetic has protein leak in the urine. So we have a whole list of kidney diseases in diabetics which they may not have a protein leak in the urine. And younger diabetics are more vulnerable. They have more number of years to live. So the fact that they may develop complications because of diabetes is generally more. The other small thing is that everyone, the minute they think that they have kidney disease, the first thing is they want to cut all the protein in their diet. And one of the things that I want to emphasize is there is no need to cut down protein completely, because as Indians, we already consume very less proteins. So vegetarian proteins are not bad, and maybe just cutting down a little bit on animal protein should do the job. So there is this, I have seen patients who come to our clinic where they just completely stop eating protein thinking that it's going to help them. But malnutrition itself can actually lead to the progression of kidney disease. Lavanya ma'am, please enlighten us, what is the right and practical way on how to follow up our patients with diabetes? Because the main problem in India is that they will come once, then what will happen is they'll be like, they go to various specialities, various native medications, because they feel it can be cured, diabetes. So how do we ensure that these people come for follow-up in a very practical manner?
So first thing is we have to talk more, we have to spend some time with the patient. Without giving straight away giving prescription, we should explain the complications related to diabetes. So we should tell them why we are screening, why we are treating, and how we can prevent the complications and all. We should talk, and we should take the help of diabetes educator also. So with that we are managing in our hospital. We have a separate diabetes educator, and every visit we have to motivate them, because it is not a simple disease, it is like chronic thing, so they have to continue treatment for a long time. So somewhere they will have that thing, if there is any promotions like they can stop medications if you take this kind of powder and all, they'll go there. So again they'll come with other complications also.
Very nicely put. Kannan sir,
I will add on this. See, we have EMR platform, but I don't have EMR platform, I have only manual work. So we are in the era of digital technology. We are basically dealing with AI. We know about the ChatGPT also. Very simple one thing. Education we are telling at the clinic itself, but sending messages is one of the important scenario, because we did a study on behalf of Nandita Arun in diagon trial. They was driving the data regarding sending SMS to the patient, how the message will be reaching the patient, how the patient will get energized, how the patient get authenticated or educated by seeing the message, because one simple message will be addressing the patient so that they can reach to doctor immediately, so that because it's a good reminder for them also. So sending message is one of the important protocol in our clinical practice to empower the patient, to address the patient, and also to educate the patient to go for the recurrent checkup once in 3 months or once in 4 months according to the CKD burden, because CKD burden we know that 0 to 5 we have. Up stage 4, stage 5, it is not possible. The patient go for the dialysis. Ultimately, the patient, if they go for dialysis, makes a huge burden and disturbs the whole family also by distorting the quality of life and outcome, not only for the patient, but also the attendant over there inside the family.
So we've been talking about
கண்களை பாதிக்கிறது, கிட்னியை பாதிக்கிறது, கால் நரம்பை பாதிக்கிறது, இதெல்லாம் வந்து சிம்பிள் மைக்ரோஸ்கோப், பட் அதுவும் முக்கியம். இப்போ ரீசெண்டாக வந்து we did a data by Professor V. Mohan and Anjana Etta. They found 4 clusters in type 2 diabetes. டயபிட்டிஸ்ல வந்து டைப் 2 டயபிட்டிஸ் நாங்கள் 4 விதமாக பிரிச்சிருக்கோம். அந்த 4 விதத்தில் வந்து டயபெட்டிக் ரெட்டினோபதி, டயபெட்டிக் நியூரோபதி வந்து ரொம்ப காமன் சொல்லிட்டு கண்டுபிடிச்சிருக்காங்க இந்தியன் சினாரியோவில். More than that, of late, nowadays we are dealing more and more with the heart failure. So the phenotypes, Indian phenotypes, not only on the metabolic burden, not only on the vascular burden, but we have the burden on the myocardial burden. That is, pumping of the heart also is one of the major important criteria to be implemented in our practice, because almost 50 to 60% of the diabetic population, which is a type 2 diabetic population, will they have the heart failure in any form, in the form of preserved ejection fraction failure or reduced ejection fraction failure. அதாவது பம்பிங் வந்து கொஞ்சம் பாதிக்கப்பட்டு ரொம்ப காமன், because diabetes, heart and kidneys are interrelated and integrated.
I think in the previous panel, as one of the cardiologists rightly said, there are non-modifiable risk factor. நம்ம வீட்டில் நம்ம ஃபேமிலியில் ஆல்ரெடி இருக்கு, ஜெனட்டிக் ப்ராப்ளம் இருக்குன்னா we can't change that. But the modifiable things like weight, lifestyle, physical activity, diet, which forms a very important part in the prevention, is something that we all can work towards in the form of a very good communication between the doctor. And I think a dietitian plays an extremely important role in any of our clinics, whether it is a nephrologist clinic or a diabetologist clinic or a cardiologist clinic. இப்போலாம் நிறைய hospital, like most of the hospitals including the government, encourage master health checkups. For picking up diabetes, who do you think should go for these master health checkups early in the course?
Madam, நீங்க ஏற்கனவே சொல்லிட்டீங்க, those who are genetically predominant, வீட்டில் வந்து அப்பாவுக்கு இருந்துச்சுன்னா பிள்ளைங்களுக்கு வந்து 50% வரதுக்கு சான்ஸ் இருக்கு. அப்பா அம்மாவுக்கு 2 பேரும் இருந்துச்சுன்னா 100% வரதுக்கு சான்ஸ். This is genetically, that is non-modifiable. Then ethnicity, Indians are predominant for the complications. Even though India is the second capital of the world in prevalence of diabetes, but we are the epitome for diabetes complications. These are the label are given by American Europeans. இது வந்து நம்ம badge of honor இல்ல, இது badge of thing to be considered earlier. So at this stage, நம்ம வீட்டில் அப்பா அம்மாவுக்கு இருந்துச்சுன்னா பிள்ளைங்க வந்து அட்லீஸ்ட் once in 3 years வந்து ஒரு செக்அப் பண்ணுறது நல்லது. தட் இஸ் இப்போ ரீசெண்டாக வந்து we have the data have been published by RSSGI latest. our RSSGI means எங்களுடைய unique research firm from the national RSSGI. அவங்க என்ன சொல்றாங்கன்னா, ஒன் ஸ்கூல் முடிச்சுட்டு காலேஜ் என்டர் பண்ணும் போதே வந்து they have to do the complete muscle checkup to rule out any pre-diabetes or to rule out any dyslipidemia or any other some manifestation over the health. That is very important.
So I think before I go on to the ophthalmologist, many patients do ask, can we prevent kidney disease in a diabetic and other complications? Yes, we can. We have a lot of good drugs now which we can use in the right patient. It's not right to self-prescribe, so going to a diabetologist and kind of asking them whether there are any good drugs that they can prescribe for prevention of kidney disease and other complications of diabetes is a must. And please do talk to your dietitian as well as your doctor regarding the diet and lifestyle practices. Coming to both our well-accomplished ophthalmologists, my first question is to Dr. Saraswati. Is there an increase in diabetics coming for eye screening? And what are all the diseases which commonly affect the eye in diabetes?
Yeah, there is a increase in the number of diabetic patients we see in our clinical setup. More than that, I would say we are seeing people in the end stage of diabetic retinopathy. Meaning initially we would see them in the earlier stages. Now we are seeing more and more people with a severe and proliferative diabetic retinopathy. So, couple of things. One, nowadays most of the people are following alternate medication. So all this WhatsApp and media, they are giving lot of, there is a cure for, there is a fruit or a vegetable which can cure everything, right from cancer to everything. And without question, they just take it up. When they come to ophthalmologists or doctors for any consultation, when we prescribe something, they ask a lot of questions. What is the side effect of the medication, how long I should, but when it is coming from a media, from an ad or from a WhatsApp, without question, they are taking it up. So they think, and another thing is diabetes in the earlier stages, especially diabetic retinopathy, without the central involving macular edema, they are asymptomatic. So it becomes pretty difficult for us to convince they still can have diabetic retinopathy with a reasonably good vision. So it's very important whenever we see the patient, we spend time with them, try to build the rapport because it's going to be a long journey. So we educate them, it is a disease which affects from head to foot and it is not an isolated thing, it can only be controlled, it cannot be cured and they need to come for regular reviews and all those things. And we specifically also mention this alternate medication is not going to help. It might in fact, and the funny thing is most of them, they'll advise them not to check their blood sugars for 6 months.
Yeah.
So they wouldn't even know what is the blood sugar level. So these are all the things which are specific to our setup and most young generation is also coming because of the oft repeated things like obesity, very high salt diet, and in gym goers and people they are taking protein diet which is again a strain on the kidneys and other things. So we do see an increase in the number of patients with diabetes.
டாக்டர் தீபக், ஸோ நிறைய தடவை எங்கள் கிளினிக்கில் நாங்கள் கேட்கச்சு உங்களுக்கு ஐயில் எதனா ப்ராப்ளம் இருக்கா, டயபிட்டிஸ்னால ப்ராப்ளம் இருக்கா? த ஒன்லி திங் தட் எஸ்ஏசியில் எனக்கு கேட்ராக்ட் ஆப்ரேஷன் பண்ணியிருக்கோன்னு. அதர் திங்ஸ் தட் கேன் ஹேப்பன் இன் த ஐ பிகாஸ் ஆஃப் டயபிட்டிஸ்.
Yeah, diabetes can cause a number of issues. One is cataract. It's just a risk factor of cataract. Apart from that, most common thing which is presenting in our department is diabetic retinopathy. Diabetic retinopathy is it's a condition in which chronic diabetes, that is over a period of duration adhigamaga there can be retinopathy changes, that is there can be changes in the retina that are visible. There are 4 stages in fact. Early stage gross up pirichiknuna, there can be early stage as well as late stage. Early stage is of diabetic retinopathy na, what we can see there are certain signs in the retina adha நம்ம பார்த்தா ஐடென்டிஃபை பண்ண முடியும். Patients won't have any specific symptoms. Late stages la vandana there can be macular edema, that is edema na retina la vandu neer kothukra thanma irukkalam, illana there can be hemorrhages, there can be bleeding or there can be retinal detachment. Retinal detachment na nerembu vandu nagundrum edatha vittu retina will be split from its position. So macular edema and the hemorrhage, bleeding plus retinal detachment வந்துச்சுன்னா the management protocol is very very big. அதாவது ஒரு 2-3 years continuous treatment தேவைப்படலாம், surgery தேவைப்படலாம், injections தேவைப்படலாம், medicines continuous follow up தேவைப்படலாம். But early stages if we try to detect it, then a lot of economical as well as patient oda health எல்லாமே வந்து prevent பண்ண முடியும்.
Saraswati ma'am, what's your protocol for a patient who comes in first and for an eye issue and then you find out they have diabetes related problems? What all do you ask them to check from your side or you just refer them to a diabetologist and take care?
Like whenever we see a patient with, if they are generally coming for the eye checkup and we find out they have diabetic retinopathy. See, like Dr. Deepak has mentioned, in the initial stages they may not have any eye-related symptoms. Only when we dilate and examine, we will pick up the changes. So that's when we try and spend time with them. because it's going to be a long haul. We sit and we explain them, this is a disease which is affecting all your blood vessels, and eye being a place where we can visually see all the blood vessels. And interestingly, diabetic retinopathy also tells you that patient might be having diabetic nephropathy, because chronologically it's a nephropathy that occurs first and the retinopathy later. So we inform them that and most of the time we show them the fundus pictures, the Google pictures. We tell them this is how, because your center is spared, the seeing portion is spared, your vision is good. So we educate them and we tell them to control their blood sugar, control their blood pressure, and also go back to their physician or a diabetologist to screen for the pathology in the rest of the parts, for nephrology, for cardiovascular risk and other things. And we advise them depending on the staging. We have criteria, like if it is early NPDR, it can be 6 to 9 months, depending on the compliance of the patient, depending on how much the patient is able to understand the problem. And we also tell them the advantages of getting it treated in the earlier stages rather than waiting for the severity of the problem where it can bleed into the eye, where the retina can detach. In that case, it's mostly a surgical intervention.
Yeah, so it's so important when somebody has retinopathy, we need to look whether they have kidney disease and other microvascular complications. We are in a clinic, actually, whenever a diabetic comes with any sort of kidney problem, we do screen the eye. So we have small AI screening tools where we can actually see and then refer them back to the ophthalmologist. So it's a very mutual understanding, which is very important among the doctors as well as the public in order to do this. Can you have blindness due to diabetic retinopathy, Dr. Deepak?
Yeah, that's what I've been saying. The thing is, it has to be detected at very early stage. When it is not detected, that is over a period of 5 to 10 years, it can progress very, very slowly. But when it's progressed, to an end stage, it causes total blindness. So certain things are reversible. Suppose if the patient is having cataract, so we can reverse it by doing surgery and the patient will get good vision. But if the patient is having retinopathy, he might develop bleeding. Bleeding is partially reversible. That is, we can do operate and reduce the amount of bleeding, and to prevent recurrence, we try to do laser and maintain the vision to a normal level. But if the glycemic control is still not under control, then he might develop bleeding again. So proper follow-up is required. Another thing is total blindness due to retinal detachment. Retinal detachment is a very grave complication of diabetic retinopathy. So there are various stages. There is tractional, rhegmatogenous, that is brake-related retinal detachment. These things have to be operated as soon as possible. So what we can do is we can partially recover the vision and maintain the vision to about 40 to 50%, but still we cannot get the quality of vision back to itself. So my basic advice will be to screen as early as possible, especially for type 2 diabetes. You have to screen whenever you get detected with diabetes. Do have a fundus screening, just a half an hour to 1 hour procedure maximum. We just screen and keep you on regular checkup and keep you on regular follow-ups to maintain your healthy vision as well as good quality also, good quality.
So before we go to the questions, can in 1 or 2 sentences, what do you want to convey about diabetes and its related complications, Dr. Kannan?
Friends, diabetes and obesity are the mother of the non-communicable diseases. In this august audience and before the public, I want to render an important message. We want to follow the ABCD mantra. Control the HbA1c less than 7. That is very, very important. It's a magical mantra. And BP. Have the BP control 130 by 80 and not 140 by 90. 130 by 80 is our control of BP, of Indian phenotypes. Recently, Professor Venkat S. Ram has given the optimization of BP control to have the BP 110 by 80, but very difficult. At least 130 by 80 will be ideal. Then C, cholesterol, LDL, the culprit for the heart, the culprit for the diabetes. They are easily clustered to form the cardiovascular manifestations into more than 50%. Target the LDL cholesterol less than 7, and D is disciplined lifestyle by means of physical activity, quitting the smoking, avoidance of the alcohol, and following the drug pattern properly. That is very, very important. Eat on time, sleep on time, eat slowly, and eat healthy. Sleep daily for at least 7 hours. That is very important chronobiology. Sleep is an important pattern in diabetes management because melatonin hormone will regulate the glucose oscillations properly in the night also. Sleep properly and be physically active. Avoid stress. Stress is a marker for the sympathetic activity that will surge the catecholamines and will implicate with the diabetes dysfunction, and keep smiling. This is a humble mantra I want to render before the public here. Thank you very much for giving me the great opportunity.
Any questions? We'll take maybe 2 questions. We don't have time.
But in case we do, okay, we have one, we'll just go with one question, but the doctors are available for a one-on-one discussion right after this panel discussion. If they have any questions, they can meet you, doctor. Yeah, but we'll just go with one question. Okay, thank you for this, was very informative. I just want to know in the autistic spectrum, for families with autistic, how do they get well informed? Because all the signs are more verbal. So how do we educate the autistic spectrum with regards to the signs, with regards to diabetes, and with regards to hypertension of the same? Are there any ways to educate?
And Dr. Lavanya.
You can answer things.
Yeah. Pictorial. So we do have a library of normal retina and stages of retinopathy, talking about eye disease. We can show them and educate them. We also have models of eye, wherein we can explain them what are the parts of it and where exactly the diabetes affects. In fact, diabetes is a disease which affects from head to foot. I think doctor would agree with us. So it's like an integrated thing. It is a disease of the blood vessels, the small blood vessels, so it is going to affect every part of it. So whichever is there, nowadays all this Google pictures and 3D videos and educative tools are available, abundant. We can use them to educate this kind of section of the population.
So regarding the diabetes, regarding the special child, if the special child belongs to the diabetic parents, so we want to render the Bakkaletedi Marthu, so we advocate our government authorities, are we supposed to educate the parents to do the home monitoring itself, or otherwise if there is any pedigree positivity for the type 1 diabetes, then we want to rule out the child is belong to the type 1 category of diabetes, because type 1 diabetes is totally autoimmune, that is only insulin is the only answer. Then we have another category of diabetes, so-called as MODI, maturity onset diabetes in young, that also we want to rule out in the special child, that we want to implicate properly. So type 1 diabetes, MODI diabetes, or any strong family history of diabetes, you want to focus for the special child in this scenario.
Thank you. One last question. I just want to know, are there any kind of different methods of testing, whether it's city bred and village bred, village audience, farmers audience and local audience between city, and because the lifestyle, the way, the physical activity, everything, the food, everything differs. So with regards to diabetes testing, is there a difference in testing, or is it neutral and is it the same?
So now recently they did a study in our India, a CORB study and other study, and doing a study in urban area as well as rural area. There are no such much difference. Only the prevalence is showing with 36% in the urban area, with 24% in the rural area. But regarding the investigation part, the same only. Regarding the advocacy part with physical activity and dietary, but also same only. Because now rural population also are eating this one burger and pizza, and also we want to focus on them. We want to educate on them. So eating healthy is one of the important messages we want to render before closing our talk.
Thank you.
Thank you.
Thank you so much, Dr. Rajiva, and to our panelists. And we have a small token of appreciation. Can I request Rehan to bring that on stage, please? And Dr. Rajiva to please present it. A few important things were spoken about, like we had our audience ask us, is the treatment different for rural and urban? The interesting thing is not man's disease, and it's reached rural India, and that seems to be a concern, and that's why events like this matter a lot, because the lifestyle choices are not so different in the rural India when compared to the urban city life. And like we spoke about CKDU, which is also hitting the rural India, and reasons are still not so known, so it's called unknown for as of now. And another important thing, can we request Dr. Sumit to please hand it over to Dr. Rajiva Salochana. And another discussion that happened last people coming for late retinopathy, and that is because of alternative medicine. We may take the opportunity as a person from the patient advocacy body that alternative medicines have played a huge role in progressing CKD from stage 1 to stage 5, and I think patients seated over here will definitely agree with me that most patients could have been saved from dialysis, but alternative medicines, well, I don't have anything against alternative medicines, but once you're on the journey of chronic kidney disease, alternative medicines is a huge disaster and only lands up in you reaching stage 5 sooner or later. So thank you so much to our diabetologist, ophthalmologist, and our lovely Dr. Rajiva. We move on to our next panel discussion. It will be interesting for you to a large percentage of women in this room will agree that pregnancy is a huge contribution to kidney disease. And we also want to mention today, while mothers are picking up kidney disease during pregnancies, today children are born preterm and also picking up kidney disease by a young age of 10 itself. So our next panel discussion is one of my favorite discussions, where we're going to have the specialist, the gynecologist on the dais, and to moderate this session we have Dr. Sukanya, a pediatric nephrologist from M Hospital, to join me on the dais, and Mehta Hospital. Dr. Sukanya, can I request you to please join me on the dais? And our panelists will include Dr. Joan Kannan from Tiruchi, Dr. Priya, Dr. Dr. Shanti, and Dr. Shobana. We have an eminent group of panelists on this discussion, and we'd like to keep this discussion engaging for the women over here, and I'm sure Dr. Sukanya will do a great job of that. To join us on the panelists, we have our patient, Shanti. Shanti is Asia's longest dialysis patient. She's been on peritoneal dialysis for the last 20 years, Shanti? Yeah, for the last 20 years. And she picked up chronic kidney disease on pregnancy. So I think she'll be the best person to give us her perspective on this subject.
Yeah. One more mic. So very good afternoon to all of you. I'm Dr. Sukanya. I'm a pediatric nephrologist, and today we are going to speak about women's health and how kidney disease can affect women in various stages of their life. But more importantly, pregnancy appo kidney disease varuma, vanda devlo common. We all think that pregnancy is a normal process. General public usually that perceive pandranga. It is normal for majority of us, but it is also a time when kidney disease can strike you, or sometimes you get to know that you have kidney disease only during pregnancy. And to speak about it, we have, I should say, an all-women panel in this program, and we have eminent gynecologists to speak to you, and we also have Dr. Rema Chandra Mohan. She is the director of ICH. She's also a neonatologist, to speak about what is the effect of kids because of maternal problems. And probably the best person to speak about kidney disease affecting women is Mrs. Shanti here. She will share her own journey with questions to these panel members. To jumpstart the session, to Dr. Jayam Kannan Madam. எதுக்கு pregnancy-ல நம்ம kidney disease பத்தி பேசணும்? Why at all kidney disease pregnancy? இந்த டாபிக் பத்தி எதுக்கு பேசணும்? எதுக்கு kidney disease screen பண்ணோம் pregnancy-ல?
கிராமத்துல ரொம்ப சாதாரண வார்த்தை, உப்பு நீர் இருக்கா பாத்தியா? We all have forgotten that, because our teaching has come to be proteinuria is not the early manifestation. But still, with our 26 million delivery, this kidney is a very, very important problem. With my probably 50 years of my deliveries, which I started in 1917, my first delivery at a rural area. Thanks to CLI patients like Shanti, who are now coming for delivery with the kidney transplant and on dialysis. Checking up the urine is the most important one, because to put it under the microscope, a centrifuged albumin specimen urine, look at the pustules more than albumin and sugar. Thank you.
Okay. It is also important to note pregnancy in a normal process the kidney and many organs in our body undergo so many changes during pregnancy that itself will put you at risk for disease. And during pregnancy and in the time, because pregnancy is a course of say 9 to 10 months, so in the course la enna madri diseases a specific timing irukka?
Good afternoon. Thanks for the opportunity. In pregnancy, the common renal problems starts with the simple, otherwise the most frequent urinary tract infection. Though it appears very simple, if not treated, it can lead to lots of complications, both for the mother and for the growing fetus. So apart from urinary tract infection, the other common things include in hyperemesis, oliguria, reduced urine output, mainly because of dehydration. The other problem may be retention of urine. The growing uterus can press upon the bladder. That is also a most common and frequent problem the mother can approach us. And otherwise, the usual two culprits, and we have been talking volumes, the diabetes and the hypertension. The patient may have a pre-existing diabetes or a known hypertensive who is pregnant now. The problems of this, or a mother can develop both pregnancy-induced hypertension as well as gestational diabetes. Both can again cause renal damages. Of late, we too come across a lot of mothers, kidney recipients, kidney donors, and some of the mothers having congenital abnormalities. This is probably the first time she is submitting herself to a medical examination. We do come across lots of congenital abnormalities, especially the undescended kidneys, double ureters, single kidney, and other issues as well.
Thank you, ma'am. Again, coming back to Dr. Jayam Kannan. Ma'am, you said நிறைய வாட்டி symptoms வெளியில எதுவும் தெரியாது, urine test பண்ணணும், urine test பண்ணி கண்டுபிடிக்க முடியும் அப்படின்னு. But if at all சில symptoms and signs pregnancyல வந்ததுன்னா இதுதான் kidney disease இருக்கும், கண்டிப்பா இந்த symptom sign இருந்ததுன்னா நீங்க கண்டிப்பா போய் kidney disease-க்கு டெஸ்ட் பண்ணணும், அந்த மாதிரி ஏதாவது symptoms and signs? So that
நிச்சயமா இருக்கு. கர்ப்பத்துல அடிவயிறு வலினா எல்லாரும் அது மங்குத்து வலி, சூட்டு வலி, இது ஒரு சாதாரண தமிழ் வார்த்தை, false pain. But people forget that it is the symptom of the infection which Shanti mentioned as a commonest cause, which can lead on to the second biggest mortality in pregnant women, hypertension complicating pregnancy. So this abdominal pain, especially in the front, in the lower abdomen, and pain on the sides. இந்த ரெண்டும் இருந்தா கட்டாயம் பார்க்கணும். ரெண்டாவது வாந்தி, கர்ப்பம்னா வாந்தி தான் எடுக்கும், அதுக்கு மருந்து சாப்பிடணும்னு அவசியம் இல்லை, சும்மா படுத்துக்கிற போறோம். அதுக்கெல்லாம் நிறைய ஹெர்பல் மெடிசின்ஸ் ஆல்சோ prescribe, மாதுளங்க ரசாயம், this, that and all. But an unusual vomiting in a pregnant woman not controlled with a regular antiemetics is also the second one. Third, the fatigue, which is also said to be a very common thing. கர்ப்பமா இருந்தா அப்படியே அசதியாக தான் இருக்கும். No, sometimes you have to examine the urine and find out whether she has a problem, and especially when we do a scan, especially in the first trimester, we have to look at the kidneys also. Of course, there are all these things. Definitely patient goes to the hospital for the same, for this pain persistent in the lower abdomen, lower pains, side pains, it's fatigue, unusual vomiting are the ones which get missed and land up only with hypertension complicating pregnancy.
Okay, Thank you, ma'am. Although you said people, but என்னதான் இருந்தாலும் ஒரு 10 வருஷம் 15 வருஷம் முன்னாடி pregnancy நிறைய பேர் they won't come to the hospital even இன்னும் கொஞ்சம் முன்னாடி. But nowadays at least they come into contact with a health person, some related person, health center, it could be a local. என்ன மாதிரி டெஸ்ட்ஸ் வந்து கிட்னி டிசீஸ் நீங்க சஸ்பெக்ட் பண்ணீங்கன்னா அடிஷனலா you will do some tests, Dr. Shobna.
Good afternoon. Thanks for the opportunity. So the antenatal care direction has changed a little bit now. Pyramid of care and shalom. So as we advance in pregnancy, we have more number of visits and more tests done. But ippo vandu the awareness that we should screen for certain conditions, be it obstetric conditions or medical conditions in early stage of pregnancy. Of course, preconception care is the most ideal. அப்படி இல்லைனாலும் கொஞ்சம் early pregnancyல கண்டுபிடிச்சு risk stratification and risk-based antenatal careங்கிறது இப்போ the present concept. அதனால எப்பவுமே ஒரு pregnant woman earlier they book the better. Gone are the days when 5 மாசம் கழிச்சு பார்த்துக்கலாம் 3 மாசம் கழிச்சு பார்த்துக்கலாம். By then the damage may be done. ஏன்னா நிறைய அட்வைஸ் நம்ம கொடுக்கறது the impact is going to be maximal if we start early. Very simple things like gestational weight gain early on in pregnancy does the damage. So first 3 months la gain paninale you are prone for gestational diabetes, and we know gestational diabetes is a forerunner for diabetes later on in pregnancy. So adanal first early gestational age le nama vandu of course obstetric side la we screen for certain things, but general side la blood pressure to check the urine for sugar and protein, and even urea and creatinine. This is not followed routinely in many places, but almost all the government hospitals do this. Even cardiac evaluation is done. எல்லாமே வந்து I think it is mandatory for a pregnant woman, because this is an excellent window of opportunity. That is like we say, we are in an excellent rapport with the patient for 10 months, and the compliance is also very good. நம்ம என்ன சொன்னாலும் pregnancy-ல மட்டும்தான் patients compliance is the best. அதனால அந்த opportunity we should grab and screen for as many conditions as possible. Of course, cost effectiveness பார்க்கணும். We should not be ordering very exotic tests, exotic investigating modality. முக்கியமானது simple things like renal disease, cardiac evaluation, and hypertensive disorder, diabetes, and few based on the symptoms, few other conditions should be screened.
Okay. I should say definitely Tamil Nadu and the health system is so good, and over the last many decades maternal and antenatal care அப்படிங்கிறது it has improved by leaps and bounds. Our complication rates are so little now. There is something that we are proud of. But I think இன்னுமே வந்து late presentation to the hospital அப்பப்போ பார்க்க தான் செய்கிறோம், both in the private sector and in the public hospitals. So Priya, in your experience, எப்போ இன்னும் லேட் ப்ரெசன்டேஷன்ஸ் வராங்களா? வந்தாங்கன்னா என்ன மாதிரி காம்ப்ளிகேஷன்ஸோட, எஸ்பெஷலி கிட்னி ரிலேட்டட் காம்ப்ளிகேஷன்ஸ் எதோட வராங்க?
ஓகே, தேங்க்யூ. ஸோ வந்து யூ ஜஸ்ட் ஹேவ் டு see 10 வருஷத்துக்கு முன்னாடி இருந்ததுக்கும் இப்போக்கும். ஃபர்ஸ்ட் 10 வருஷம் முன்னாடி we never used to do creatinine routinely. Now we are doing it. Maybe for the past 3-4 years, every medical record they come with the first trimester, first visit the serum creatinine is already done. So அது முன்னாடி பண்ணலாம் அப்படின்ற அந்த மாதிரி situations where some people they present late, they come late, they miss the first test, அந்த மாதிரி patient they land up with preeclampsia during pregnancy. That is a superimposed preeclampsia will happen because of the pre-existing renal disease which is missed. இதே வந்து அவங்க first trimesterலே create பண்ணிட்டாலோ இல்ல ஒரு யூரின்ல albumin positiveோ இல்ல BP check பண்ணி BP high-ஓ this could have been prevented. இந்த late presentation வராது. So what will happen is that because of BP they may come with fits. அது ரொம்ப காமன். pregnancy-ல ஜன்னி கண்டு வரதுன்றது everybody will say pregnancy-ல ஜன்னி கண்டு அதெல்லாம் பரவாயில்ல அப்படின்னு. And it was like not life savable before. Maybe 10-20 years the eclampsia death rate was very very high. இப்போ அந்த மாதிரி it is very very less because we are taking home, and even the ANMs are doing a very good job of screening them early. That is one. Second thing வந்து நம்மள அந்த வளகாப்பு பண்ணுவாங்க. It has a lot of benefit in that. So என்னன்னா when generalized edema வரும்போது கையில அந்த வளையல் வந்து டைட் ஆகி அந்த வளையல் மார்க்ஸ் வந்து will be seen in the hand, and that was a concept of earlier starting of வளகாப்பு. Two concepts. ஒன்னு வந்து அந்த வளையல் சத்தத்துல vocal stimulation for the baby. So அது வந்து will be like அதோட intelligence improve ஆகும். Second, இந்த வளகாப்பு சத்தத்துல
அந்த வளையல் டைட் ஆச்சு கையில பதியுதுன்னா they come to the hospital.
Okay.
உனக்கு கை வீங்குது, that is how they detected. கை வீங்குது, கொலுசு கால் வீங்குது, அப்படிதான் வருவாங்க. Most of the time edema for the layman it is like that. வீங்குதுன்றது before it becomes like generalized anasarka, they come to you with these things. So other some very rarely they present with decreased urine output. அது வரைக்கும் போக மாட்டாங்க. Most of the time pregnancyல வரணும்னாலே they'll come back with preeclampsias. So BP வந்துடும், BP related complications ஓட they will definitely land up.
Okay. ஸோ சில சமயம் வீட்டில் சொல்கிறது கேட்கறது இட்ஸ் குட்னு சொல்கிறீங்க, வளகாப்பணும். ஓகே, தேங்க்யூ. ஸோ இவ்வளோ நேரம் வி டிஸ்கஸ்ட் என்னென்ன மாதிரி ப்ராப்ளம்ஸ் வரலாம், என்னென்ன ஆப்பர்ச்சுனிட்டிஸ் இருக்குது கிட்னி டிசீஸ் ஐடென்டிஃபை பண்ணுறதுக்கு. ஸோ ஒன்ஸ் யூ நோ சம்படி ஹேஸ் கிட்னி டிசீஸ், அவங்களுக்கு டெலிவரி பிளானிங் என்ன மாதிரி கவுன்சிலிங் என்ன மாதிரி இதெல்லாம் யூல் பி கிவிங். டாக்டர் ஜெயம் கண்ணன் ப்ளீஸ்.
கிட்னி டிசீஸ் அப்படின்னாலே கட்டாயம் நான் இறந்து போயிடுவேன் அப்படின்னு நினைக்கிறத மனசுலேருந்து எடுத்துருங்க. கிட்னி டிசீஸ் எங்கே வைத்தியம் செய்யணும் அப்படின்னா நிச்சயமாக ஒரு சிங்கிள் டாக்டர் யூனிட், அவங்களே தான் ஓபி பார்ப்பாங்க, அவங்களே தான் பிரசவம் பார்ப்பாங்க, அவங்களே தான் ஆப்ரேஷன் பண்ணுவாங்க, அவங்களே தான் டெலிவரிக்கு அப்புறம் வார்டையும் பார்த்துக்குவாங்க. அந்த மாதிரி சிங்கிள் டாக்டர் பொட்டிக் யூனிட் இருந்தால் அதில் கொஞ்சம் டெலிவரி பார்க்கறதுக்கு யோசிக்கணும். யூரின்ல 2+ பார்த்தாச்சு, பிளட் ப்ரெஷர் 130/90. இந்தியா பொறுத்த வரைக்கும் லக்ஷயால ரொம்ப கிளியரா சொல்லிட்டாங்க. All are small women in India, her blood pressure is only 100/60/70. Any woman developing blood pressure 120/80 itself, please be careful, look at it. Secondly, a patient with pulse rate of more than 95 as a persistent tachycardia. இவங்களெல்லாம் நிச்சயமா இந்த மாதிரி சிங்கிள் டாக்டர் யூனிட்ல டெலிவரி பண்ணக்கூடாது. அப்போ யார் கூட இருக்கணும்? நிச்சயமா ஒரு பிசிஷியன். சாதாரணமா கிராமங்கள்ல இந்த மாதிரி டவுன் ஏரியாஸ் லைக் திருச்சி, சென்னை ஒரு கிட்னி டாக்டர் அருகில் இருக்கக்கூடிய இடமா இருக்கணும். அப்படின்னா அவங்க கிட்னி டாக்டர் நிச்சயமா இந்த பிரைவேட் சென்டர்ல வந்து பார்த்து என்ன செய்ய முடியாது. அதனால முடிஞ்ச வரைக்கும் இந்த மாதிரி கேசஸ் சிங்கிள் டாக்டர் யூனிட் or unit without any facility for looking at, as Priya said, looking at the blood values immediately like serum creatinine, blood urea, urinary protein, all these things. Please have only delivery at a place, tertiary hospital, so that you are safe. You don't have problems. You recover back 100% and go back like Shanti and continue your care. Thank you.
Yeah, thank you. Now we would like Mrs. Shanti to share her experience, because she is somebody who's lived through a pregnancy and had to face the consequences of having a kidney problem during pregnancy. Adukapprama she successfully come out of it, but she definitely had some kidney problems after that. So Mrs. Shanti, please share your experience. I think that will be the most valuable to the audience here today.
I first have to thank Tanker Foundation and Kidney Warrior Group for inviting me to sit with such eminent doctors. I'm not a doctor, but like out of experience, I've started learning so much about anatomy. When I was 7 months pregnant, like every month I would go to the gynecologist and she would check my urine report. This was in 1999. So she would check my report, and it started like this. I was very naive. I didn't know what the significance of each of the readings were. So albumin would be 1+. The second month it went to 2+, then it went to 3+, then it went to 4+. I didn't know what it meant. And my gynecologist would see it, and she said, "Enna 4+ irukku, unoda BP check pannalam va" appdin sonna. And when she checked, she said, "It looks normal." She said, "Oh, maybe my BP equipment is not working. So can you come to another clinic that I have?" So when I went there, she was shocked to find it was 200/160. And she said, "You can't get out of bed. You just have to be totally on bed rest." And she suggested I go see a nephrologist, whom I did go and see. He said, "Your kidneys are not a great shape and it is affecting you. So I would suggest you take these medications." So I did take those medications. I came home, had lunch and had the medicine. By 5, I started having loose motions. I became so tired and weak. And when I called him, he said, please stop all of the medication and consult your gynecologist. So I consulted my gynecologist, and I don't know why, but she said, I can't take care of you anymore. Please go find another gynecologist. I was in my 8th month of pregnancy, just starting my 8th month. So I didn't know what I had to do because it was just my first time and I didn't know where I had to. So I went to my GP who was taking care of me from when I was a little girl. So he suggested I go to Dr. Shanta in SMF, and she saved me and my baby. I was hospitalized for over 20 days because she was trying to bring the BP under control and stabilize me, but she couldn't. And like Dr. Priya was telling, yes, just after the delivery that day I had fits, and I didn't know what it was, and that is when they said, no, there is something wrong with your kidneys and you need to consult a specialist. I did go, and he prescribed medicines for me for my BP, but I was very careless with my medication. With a small baby, the focus daily was, Papa kellam panniya, like you do this, you give her a bath, feed her well, because the social conditioning is such, in our society. You feel guilty if you were to take care of yourself and not the child.
Yes.
So the whole day after finishing, I would put her to sleep and I would crash next to her and I would remember I didn't have my BP medication. And I'd say, it's okay, like, Chodo, we'll do it tomorrow. And I kept doing this persistently. And when my child was 3 years old, both my kidneys failed, and that's when I went to Dr. Georgie. He promised me that he would keep me up and about for my daughter. And he's kept his word. And now he's at my daughter telling, go ahead, you have to get married for your mother's sake. She's 24 now, my child. I've seen her through school, I've seen her through college, and as much as I'm proud of her, Dr. Georgie and Dr. Millie are equally proud of her. They're like second parents to her. They chide her when she's wrong, they correct her, but this is what I would like to tell people is, pregnancy cannot be taken lightly, like all you eminent doctors are telling. We need to keep an eye. I'm an MBA, I'm educated, supposed to be well educated, but I let this happen to me. So people from the underprivileged sector, I think we need to go there with full force to these women to tell them why it is important to take care of themselves first. Come to doctors like you, take good care of themselves, because we have a value for our life and we contribute to the family itself, So we need to be stabilized to make sure that our family is stabilized. And we have to take good care of our health. And luckily, I have Dr. Georgie, who has helped me, 20 years. Today I'm sitting here and talking. It's not been an easy journey. We've had many ups and downs, and he's held my hand throughout that journey. And he has helped me have a stable life, have stable relationships, and I do very well in life. I'm not just at home. I'm an entrepreneur. I run my own business now. And I am wondering, how the hell could I do this? And it is because of, I don't know if all the doctors are here, but Makkal Tedi Maruthuvam, I'm one of the recipients. I went and spoke to Dr. Radhakrishnan when he was the health secretary. I requested that I want this help because for 18 years, my family has funded me in dialysis, in peritoneal dialysis, and I said I would like it if the government can help me. And they willingly, now I have the dialysis bags coming to my doorstep every month. Okay, I don't have to go stand in queues and do it, but we go for a OP checkup every month. And this particular scheme that the government has brought forward is a wonderful scheme. Though it is for the underprivileged, they also give special cases like me, the privilege of getting free medicines. I'm so happy to have met all of you because I know we can take this forward, with all of you to the underprivileged especially, who don't have, any idea as to, like doctor was telling just now, they didn't even know, like for the first trimester, they don't even come to the hospital. They don't even bother, and most of the people at home, they say, oh, you're okay, this is normal and things like that. But I don't think these things should be normalized. We should tell them that every bit of it, from the first day, go to a doctor, and take good care of yourself.
So
Thank you for the opportunity.
Can I add to that? I think the frustrating thing all of us, all the obstetricians face is the lack of postnatal complaints. Follow-up, yes. Adhikku I think doctors can do only so much. The family, I think, is the most important. Unless there is a family support for them to come back to the hospital or even in the community to continue with the care, the investigation, follow-up, treatment, long-term. We are talking about several years to go. Like I was mentioning to someone, like just to do one postpartum GTT for a case of gestational diabetes, the uptake is like only 20% when we did a study in our own place. We have to make so many calls because there is nobody to take care of the baby at home. They can't leave the baby in. So home care, I think, is going to be the way forward. And we said like pregnancy is a window of opportunity. Pregnancy is also like a pre-metabolic indicator to follow them through long term. People with preeclampsia and gestational diabetes, obesity, even preterm deliveries, these are all the cases that we have to follow. If community la ellarkum screen pandrathu romba mukkiyam. Adhe madri in the high risk screening, we have a group of pregnant patients who have had preeclampsia, diabetes and obesity and preterm delivery. I think even effective follow-up panina, prevention being the context and theme of today's
thank you so much. Thank you so much, all of you. I think Mrs. Shanti on experience share panadlende, we can pick out many things. You have kidney disease during pregnancy, it is not so bad that you're definitely going to die or have a poor pregnancy outcome. It is always possible with proper care and in a proper center like Dr. Jayam Kannan said, which has all the facilities. You can have a good pregnancy outcome both for the mother and the child. But it's also very important, pregnancy kapro ungalku thirupi adhe problem persist agudha, adukku medicines venuman paathu, you have to continue your care post pregnancy also. So now an interesting
I want to add, now we are all talking about the medical perspective, the medical things and other thing. One thing which we have to address is also the emotional component and also to go and highlight it to the relatives that this is a special kind of women who's okay to have a few postnatal follow-up for her, and we should not make her feel guilty that one patient came and cried to me. My people are saying that you always bother about your health, you're not bothered about your baby. How dare you bother about your health? I said, Amma, if Suvaramadan Chittiram, it's always the mother is a Suvara and Kolanda the Chitram. So Suvara lose panite Chitrata vechittu onnum panna mudiyadu. So I tell all my patients it is not wrong to take care of themselves. So adu with the mother-in-law side and the relative side also it should be educated that it's okay to take care of her.
Yeah, very true. It truly impacts the whole family, and the family should stand behind all of them. So slightly shifting gears from the mother to the child, although you said the mother is very important, I'm going to go to the child now. Maternal complications during pregnancy, especially hypertension and kidney disease, definitely doesn't leave only with problems for the mother. There are certain problems that the child also undergoes because the child is developing inside the mother. So what are the common problems that we see in children who are born to patients with kidney disease?
Good afternoon to one and all. Special thanks to all of you who have included me in this panel. We all know that fetus is entirely dependent on what it gets from the mother. They cannot produce anything on their own. So anything which compromises the integrity of the placental circulation is going to have its bearing on the baby. So the baby or the fetus may even die in utero if it is a very severe hypertension or a kind of an acute event, or it can progress, but the uterus not being conducive for it to continue inside, it might come out as a preterm baby, or if it manages to stay inside, it will be a small for gestational age baby. And we all know that whenever there is a vascular compromise, it has long-standing effects. So it can produce hypoxia to the baby, which can result in an asphyxia, which can cause a cerebral palsy. Those things are long-standing problems which will impact the entire family and this child for a lifetime. And so these are all the problems. Anything that can compromise I say it's a warning bell that we should go back and see whether the baby's kidneys are functioning or not. And causes the lungs also to expand. So if you want to have a well-functioning lung, the child's kidneys should be functioning well. Otherwise, the baby will be in a kind fluid will provide. It's tightly constrained induced space which will prevent the lungs from developing. It will cause the baby to have hip dysplasia because he is tightly kept inside. He'll have a flat face. So all those things together is called a Potter's facies. So that is the significance of the amniotic fluid, which is derived from the fetal urine, which in turn is from the fetal kidney, which in turn is dependent on the placental circulation, which in turn is dependent on the mother's well-being.
So very rightly said. So one thing leads to the other, and the effect is not only for the mother, it's for the child, and in effect for the whole family. It's
modifiable factors and non-modifiable factors. In the previous talks, saying genetic history is something that we cannot modify. But now we have this epigenetic influence on the growing fetus in utero. So a mother with hyperglycemia causes fetal hyperglycemia, and this fetus is programmed to have metabolic syndrome, starting from PCOD in early adulthood to metabolic syndrome and diabetes later on in life. I think that is another reason why we should be very, very aggressive in controlling sugar. இப்போ நிறைய பேர் நம்மளுக்கு கிளினிக்ல வரப்போ சுகர்னா முதல்ல பயப்படுவாங்க. அப்புறம் இது போயிருந்தானே, இது சும்மா பிரெக்னன்சில இருக்கு, என்ன அட் த மோஸ்ட் என்ன ஆகும், குழந்தை பெருசா இருக்கும், சிசேரியன், அவ்வளவுதானே, பரவாயில்ல, they are happy having a chubby baby. பட் நம்ம இதெல்லாம் உட்காந்து அந்த 3rd or 5th மந்த்லயே எக்ஸ்பிளைன் பண்ணினோம்னா இது உங்களோட நிக்க போறது இல்ல. குழந்தைக்கும் லாங் டேர்ம் ப்ராப்ளம்ஸ், நாட் ஜஸ்ட் வெயிட், இட் இஸ் ஆல்சோ டயபெட்டிஸ் அண்ட் அதர் மெட்டபாலிக் சிண்ட்ரோம் and cardiovascular risks எல்லாமே இந்த குழந்தைக்கு இருக்கும் அப்படிங்கிறது. I think we have strong evidence today to confidently say that this is an important area for prevention.
Yeah. I think very nicely brought out many issues around pregnancy, how it impacts maternal and child health. If we could have one audience question or to close the session. On the mic.
I wish to add a point like our antenatal care and the delivery care in government. Now we have formed the mentoring care to look after those high-risk mothers even after the delivery. We have groups formed, and all the high-risk mothers, especially those with kidney problems, at the point of discharge, we are following up meticulously with the team of system that is available, and they do attend the mothers at the door care. The PHC follow-up is also now existing. And with our intense all these antenatal care, we have the booking visits right from first trimester, and we are happy to tell that the incidence of kidney problems costing the maternal life is far less.
Okay.
With our intact health system, we are able to give very good results both for the mother and the baby.
That's so encouraging to hear.
It's an encouraging point. Yeah. But we don't miss any of the renal problems costing maternal death
okay.
and pregnancy. That's something very good to share to all of you.
Yeah. Do we have a question, Marianne?
Yeah. Hi everyone. I just have a question. We spoke about postnatal consultation after pregnancy. How many months after the delivery we should see the doctor? Once in 3 months, once in 6 months? How often should we follow up with the doctors is my question.
Actually, the postpartum period we mentioned, it is up to 6 weeks. It's common for all the mothers who have delivered. Especially for high-risk mothers, in this 6 weeks itself we will know whether coming back to normal or the complications still exist. So depending upon each condition, the treatment and the further follow-up also extends. If it's a mild form of disease, especially the gestational diabetes or preeclampsia, it's likely to settle within 6 weeks' time. So the medications further follow-up depends in case if they end up in a long-standing problems as per the issue. Is it for transplant, ma'am? Okay. Yeah, in those patients, actually it's a multidisciplinary approach. We usually hand over or we just guide the patients to be in touch with the nephrologist. They will give the time protocol and the treatment follow-up for the next coming months of follow-up.
Okay. I'd request Dr. Jayamkannan to add to it and also give a few closing remarks, please.
Yes. As per all the systems, Garbathila minimum 4 visit to the doctor. First visit la government la poye unga pera padivu panni RCH number alla PICMI number vaangina government sits on you to see that you deliver safely. இந்த 4 விசிட்டுக்கு அப்புறம் இந்த கிட்னி டிரான்ஸ்பிளான்ட் பேஷண்ட் கேட்டது போது அந்த பேஷண்ட் செப்பரேட் ஆகிடுறாங்க. அவங்க கர்ப்பம் ஆகும்போதே அவங்க டிரான்ஸ்பிளான்ட் டாக்டர்ஸ்ட்டு என்னென்ன மருந்து எடுக்கணுங்கிறத கரெக்டாக கேட்டுக்குவாங்க. ப்ரோட்டீன் லெவல்லாம் என்ன எடுக்கணும், என்ன ப்ரோட்டீன் எடுக்கணும்னு கேட்டுக்கிறாங்க. அவங்களுக்கு இந்த 4 விசிட்டுங்கிறது இல்லை, ஏற்படுவது அல்ல. அது ஆர்டினரி பேஷண்ட்டுக்கு தான். Transplant patient requires visit every month to the doctor in the first 5 months. After that 150 days on our body, every 15 days to the doctor for the baby growth, and then 30 வாரத்துக்கு அப்புறம் வாரம் டாக்டர்கிட்ட பார்க்கணும். டெலிவரிக்கு அப்புறம் எப்படியாக இருந்தாலும் இவங்க வந்து கிட்னி டாக்டர்கிட்ட போக மாட்டாங்க. ஏன்னா பேபி தான் முக்கியம் அவங்களுக்கு. அப்படி பேபி முக்கியம்னு வர்றபோது கட்டாயம் அவங்க இந்த ப்ரெக்னென்ட் அந்த டாக்டர் நெஃப்ராலஜிஸ்ட் கேட்டுட்டு அந்த டெலிவரி யூனிட்ல என்னென்ன டெஸ்ட் செய்யணுமோ எல்லாத்தையும் செய்து அட்லீஸ்ட் பை வீடியோ கான்ஃபரன்சிங் அந்த கிட்னி டாக்டர்கிட்ட பேசணும். ஆஃப்டர் 3 months she becomes a regular patient to the nephrologist. In general, in pregnancy, kindly be very sure, as per the latest guideline given by the United States Task Force Prevention, every visit to the doctor, I request the doctors and nurses to record the blood pressure. நேற்றுக்கு வந்தாங்க பிபி ரெக்கார்ட் பண்ண, இன்னைக்கு வந்தாங்க பண்ணணும். This is a must. This is the forerunner to warn you that the patient is going in for kidney, heart, brain and lungs. இருக்கலாம் கூடாது. 2 பேருக்கு சாப்பிடலாம், 2 குழந்தை இருந்தால் 3 பேருக்கு சாப்பிடலாம், வேண்டாம். தயவுசெய்து அந்த வெயிட் கெயின் டாக்டர் சொல்ற அட்வைஸை ஃபாலோ பண்ணுங்க. கவர்மெண்ட் ஆஸ்பத்திரியில் ரிஜிஸ்டர் பண்ண பிற்பாடு அங்கேருந்து மறந்து போயிடுறது. ஏன்னா ரிஜிஸ்டர் வந்து ஹஸ்பண்டோட ஆதார் கார்டில். அதனால என்ன பண்ணுவாங்க, ஹஸ்பண்ட் ஆதார் கார்டில் பண்ணிட்டு 4 மாதம் அம்மா வீட்டுக்கு பண்ணால் அந்த நர்ஸு ட்ரேஸ் பண்ண முடியாது. வீட்டில் பண்ணால் மாமியார் பதில் சொல்ல மாட்டாங்க, அந்த பொண்ணு எந்த வீட்டில் இருக்குன்னு சொல்ல மாட்டாங்க. தயவுசெய்து அந்த நர்ஸோட கான்டாக்ட் வச்சுக்கோங்க. அந்த நர்ஸோட பேசுறது தப்புன்னு நினைக்காதுங்க. மருத்துவத்தில் இருக்கு, அதை எல்லாரும் உபயோகிச்சுக்கணும். அம்மா வீட்டுக்கு போயிட்டோங்கிறதுக்காக ஒழிஞ்சிக்க முடியாது. அம்மா வீட்டுக்கு போனாலும் அங்கே இருக்கிற நர்ஸுகிட்ட நான் இந்த ஆதார் கார்டு வச்சு விழுப்புரத்தில் ரெஜிஸ்டர் பண்ணியிருக்கேன்னு திருச்சியில் வந்து சொல்லணும். அந்த விழுப்புரம் நர்ஸுக்கு திருச்சி நர்ஸு இன்ஃபர்மேஷன் கொடுப்பாங்க. இங்கே டெலிவரி டாக்டர்கிட்டையும் விழுப்புரத்தில் ரெஜிஸ்டர் பண்ணதுங்கிறத சொல்லணும். பிகாஸ் வி ஆல் ஹேவ் அ ஹை-ரிஸ்க் ஆன்டிநேட்டல் ட்ராக்கிங் சிஸ்டம். இதில் வந்தீங்கன்னா நார்மலாக ப்ரெக்னன்சியில் 18 to 20% பிளட் ப்ரெஷர் காம்ப்ளிகேஷன். அந்த 18 பேர் பிளட் ப்ரெஷர் காம்ப்ளிகேஷன் வர்றவங்களை உங்களுக்கு அந்த 18 பேரை 18,000 ஆக்கினீங்கன்னா ஒருத்தருக்கு தான் கிட்னினால ப்ராப்ளம் ஆகி மரணம் நேரிடும். செய்யலை அப்படின்னா இந்த 18,000ல் 10 பேருக்கு மேலே கிட்னி ப்ராப்ளம் வர்றதுக்கு வாய்ப்பு இருக்கு. இதை எல்லாரும் புரிஞ்சுக்கணும்.
Very, very, very impactful message there. And with that, we conclude this panel discussion. I should say it was a brilliant discussion from all the gynecologists, neonatologists, and from Mrs. Shanti herself. Thank you very much.
Thank you very much, Dr. Sukanya. Can I request Leja Moore from Sota, Karnataka to please join me on the dais and hand over the token of appreciation to our panelist. I think pregnancy-related complications for kidney disease needs to be more spoken about because of the growing rate of kidney disease in children, and which contributes a lot to the whole journey of pregnancy, and preterm babies that are being born and eventually picking up kidney disease by a very young age of 10 years. And anybody would like to have further discussions on this topic, our panelists will be available for a one-on-one session. You're most welcome to meet our panelists and discuss the same. Once again, a special thanks to all our panel members for this brilliant discussion on pregnancy-related complications connected to kidney disease. We'll now move on to the panel discussion, which is the most vital panel discussion because the first phase of the two killers leading to chronic kidney disease, diabetes and hypertension. This is the group of doctors who receive maximum amount of these cases. Please put your hands together for our general practitioners and family physicians who seems to see the maximum amount of these cases, and we especially speak about it. We like to understand what happens in that section. And to moderate the session, we have Dr. Raja Balasubramanian from Kaveri Hospital. Please give him a... And the panelists will include Dr. Padma with a vast experience on preventive work. Dr. Padma will bring back to the Dr. Padma, Dr. Ba and Dr. I think become we tend to go back to them. So let's hear what they have to say.
Can I have the brief, please? I don't know. One more. One more. No, one for... Good afternoon, everybody. At the outset, I thank the Kidney Warriors Foundation for having us here and welcome all the panelists. I think we understand three important take-home messages today. One is prevention. Second is the care by the family physicians, which is most important. And third thing is in case if the disease becomes an advanced, what do we do? We finished the third aspect of the session for all this time. And before we move on to the role of the family physicians towards preventing all these complications due to these lifestyle diseases, I would ask all of you one important question, the most important take-home message to all of you. We understood that it is predominantly a lifestyle-related disease that is responsible for diabetes, high blood pressure, obesity, which leads on to all these organ dysfunctions. I always believe that 1 hour in a day you spend for yourself. Correct? If you can't spend this 1 hour a day for yourself, for at least 5 days in a week to do a physical activity, I think you're going to end up with lifestyle-related diseases. Please understand that how many of you do spend this 1 hour for yourself. In case if you're not spending, hopefully you should start spending this 1 hour for yourself from today. So with this introduction, let's move on to the most important aspect of today's talk. How the basic lifestyle-related diseases like diabetes and high blood pressure, we understood that the number of people with diabetes and high blood pressure are significantly increasing. And if they say that 1/3 of the population has diabetes and high blood pressure in the society, especially in Tamil Nadu, just imagine how many of us without our knowledge is going to have this disease with us. So with this, we just move on to the question. We have Dr. Padma. Please let us know how many of your patients have diabetes and high blood pressure. Do you see an increase in the number of patients in your practice?
Yes, we have already seen an increase in both diabetes and blood pressure over a period of time. I have been practicing since almost 20-25 years, and those days we were seeing patients only after 40. 40 was the limit to have a very healthy life, and only after 40 we used to see blood pressure or diabetes or whatever it is. Unless and until the female gets pregnant, we have a kit of investigations. But now that is not the case. Any person who comes at the age of 20, especially in our setup and in our friends group, we do look for both blood pressure as well as sugar levels, and that has increased both in younger populations as well as in geriatric population. And we have made it a common entity to check blood pressure, sugars, creatinine and urine routine analysis for everybody with a minimum amount of tests, not the total battery of tests which costs a huge amount for the type of people who visit us.
Okay. See, the numbers are significantly alarming. How many of them in your practice have a good complaints to this treatment and for follow?
It depends on their education especially. The literacy, more than education, the literacy. If they are more literate, they try to come very often, as and when told. But our group have got a setup like, whenever we see a person, what we do is we make it a WhatsApp group. And whenever we tell them lifestyle modifications, we keep on posting them every day, did they do that? So that 1 month of tackling will make them very happy, and they continue to do that in a very good way, which we are seeing since, especially since 2 years. Before that it was not a great thing, but now even at 20 or even at 60, we see everybody doing all these things with a little bit of diet time, when to eat and what to eat, and also as you told about 1 hour of walking. Preferably, as in an Indian context, we have this bargaining entity, so we tell them 2 hours so that they do at least 1 hour per day.
Dr. Parandaman sir, how many of your patients, when they present you for the first time with diabetes or high blood pressure, already have end organ damage?
Yeah, actually we come across nowadays younger people are coming with new onset diabetes. Along with that, there is a proteinuria. But not every day, at least a month, we pick up 3 to 4 cases of new onset diabetes with the proteinuria and hypertension, blood pressure is elevated in that conditions. And if you screen them, they will be having cholesterol, so high cholesterol. So only cholesterol, they won't come with the report. When you screen for the cholesterol and the thyroid, and there are a few percentage, they are having thyroid problem, elevated TSH. So there were 4 to 5 patients per month. Younger individuals less than 40 years, they come with the diabetes. When they screen them, they have invariably they are having hypercholesterolemia and BP is slightly elevated. And most of the time they control, when you control the diabetes part of the controls, then we'll again screen the nephropathy, proteinuria is there. Proteinuria, few people only develop proteinuria in the initial setup in a type 2 diabetes, and we will have screening and every year for them for a proteinuria whether the patient develop proteinuria in those who detected diabetes, which is not having proteinuria at the time of presentation. That we do, and keep monitoring the blood pressure. And most of the what I found is a unique thing is when the blood pressure is taken outside, that's 120/70. When come to the hospital to me for consultation, 200/150. This is the one which is unique for me, because nowadays we go by the electronic BP apparatus. So that is sensing. As long you are calm, quiet, it gives a normal value what is there in the body. When you are tensed, anxious, the probably sensing capacity of the instrument is very high. It reflecting 200/150, which I am not able to blood pressure monitoring done at home at morning periodically. When you are casual, when you are released like that. So if it comes like that, always the BP at home is normal, like say 120 or sometimes 110/70. When it comes here is high, not invariably, but most of the time. So that's because that BP apparatus, which is electronic, what we are using now, that is probably that reflection. In addition to in general it's called white coat hypertension. Whenever patient comes to first time to a doctor because of the anxiety and the apprehension and the other things, probably the BP go up, and after some time it gets settled. So any value comes immediately first time, we will just give them education about the change of blood pressure like that, and we don't generally start medication, and we will wait them to repeatedly. And sometimes I used to check in both hands. Because first time diabetes, 25 years diabetes means he is very much apprehensive and anxious and tense. You won't talk properly. At the time, moment is 200 by 150. So once you convince about all these things, the BP settles down, and the sugar level, of course, the sugar is not a disease, it is a lifestyle problem. You want to get out of the disease, you don't, I tell you, you follow me whatever I say. Then without medicine you become all right. If you put that word, the BP drops down. We are going to prescribe medicine, that's true. But when you say without medicine, I will bring down the blood sugar. Okay? If you say like that, automatically the BP comes down, because he was reassured that, oh, doctor is able to bring down the blood sugar without medicine. That immediately comes down. You check the BP after some time, normal. So that's reflex shows, but anyway, depends on blood sugar, will be advising the medicine, not that without medicine will be, treating the patients. So that level of anxiety, especially younger individuals, it is not, this I have not found for a young, older people, like no, more than 60 years, 70 years, they come with
patient done. Do these patients listen to you to get evaluated, or they say?
Most of the time they adhere to the request, they follow it, because they are coming with some critical state, fever. Fever is the one which is really this thing. So you are having a high blood pressure because of the fever only. It is nothing to do with that, because pulse rate is high, blood pressure high, you are a high BP, high fever. So fever, everything correlates. Severe high fever, BP low go, that is sepsis, that is a different story. So but you are the potential candidate for developing hypertension, future hypertension. You are a potential candidate. So it is not that you are hypertensive now, because hypertension is caused by the fever now, fever-related problems, hormones now. Once you become more, fever comes down, BP comes down. That's I'm very clear. I'm very sure. But you are the likely candidate to develop blood pressure in future. So please monitor your blood pressure. Then I'll ask the family history, whether parents are having, or relatives are having, or your brothers, siblings are having. Yes, my brother, please check. Then of course, at that point of time, they listen to that. And subsequently, they won't come for me for a blood pressure. If at all they come for other problem. But they won't come for blood pressure. But insist them on, because you're likely candidate, because not all people develop fever developing hypertension, only few percentage they develop. So for them you insist about the frequent monitoring of blood pressure, either at home or at office, so that they can pick up.
So a very important point what Dr. Parandaman had said. See, we all know that diabetic patient checks their blood sugar at home. They have a glucometer, they check it. But how many of the patients with high blood pressure do have a blood pressure instrument at home and check their blood pressure periodically? I think it's very, very important. Like how you monitor the blood sugar. We understand that a high blood pressure is very, very important predisposing factors for either heart, cardiac disease or renal disease and so on. But we do not monitor the blood pressure. We all think that I do not have any symptom, I do not have any giddiness, I do not have any chest discomfort or breathlessness, so my blood pressure should be all right. That's what people generally think. But by the time the high blood pressure creates a problem, the magnitude of the problem is extremely severe. So I strongly feel that how somebody checks their blood sugar periodically at home, if they are a diabetic, they should have a blood pressure instrument at home and check their blood pressure. A question to you, Dr. Natarajan, in case if you find a patient with high blood pressure, what basic things that you do, or what investigations you do, or what advice you give to the patient?
See, just I want to say initially about my way of practice, irrespective of the problem what you come, whether you come for a headache or fever or cold or whatever it is, it's a mandate I check the BP myself personally in the right upper limb.
The volume is all right? Is okay? Audible. Yeah, okay, sorry, go ahead.
So I always check the blood pressure, which is very simple. Okay, that's one thing, and where I pick up at least once in a month, suddenly 260 bar, 140, 150, just like that. That's very, very important, and when you go deep into that, the history says the patient is either on long-standing painkillers or they are taking alternative medicines and currently asymptomatic, maybe a little bit of vision defect, nothing more than that. And initially they always have a big denial. No, doctor, I don't think I am healthy. Until if they have a chest pain, they will run and come to us. If they have blindness, they will come to coming to us. But otherwise, there is a big denial from them. So once when you have a elevated BP, as Dr. Parandaman said, give an opportunity, unless if it is the SL is more than 100, straight away I tell them to go for basic investigation like, a blood count, to make sure that there is no anemia. Surprisingly, once in 6 months, I find a patient with a hemoglobin of 7, where definitely the creatinine is more than 4.5. I mean, for around 3 point. I always do the fasting blood sugar, I do a blood count, I do a urine analysis, maybe an ECG. ECG will show if there is a left ventricular hypertrophy, it's a long-standing, so be very careful. And if the patient can afford an echo, that will also contribute for elevated the LVH. So then we will tell the patient that you are at risk, you have a long-standing hypertension and unattended, be very careful. Of course, the simple urine analysis gives a good clarity and maybe along with the deposits as clarity how to move on with that particular individual. These are the basic tests which we have to run through. If the patient can afford to maybe go for lipid profile, that's also very important along with the ECG.
It's a very good point, sir. I think all of us are aware that the high blood pressure, what we commonly see, 85 to 90% of them have high blood pressure related to the lifestyle. And 10 to 15% of them have high blood pressure as a result of an end organ damage causing the high blood pressure, most probably the kidney for a secondary cause of high blood pressure. Because many times high blood pressure, when it is identified, especially in the periphery, most of the time the patient gets onto blood pressure medication which they take. They don't get evaluated for an end organ damage. I'm very happy as a nephrologist that you said that the first investigation you said that is urine analysis. I'm very happy about it because many times a patient with high blood pressure gets cardiac evaluation done. As you rightly said, high blood pressure or a longer period of time can cause cardiac dysfunction. But a kidney disease is a root cause of high blood pressure. So when somebody has a high blood pressure, the first and foremost organ to be evaluated is the kidney. So now, do you have any group of patients in whom you strongly suspect a secondary hypertension? It is not generally essential hypertension.
Younger age group, people with a very high elevated blood pressure, resistant for treatment, use 2 or 3 drugs still. And of course, my teacher always used to say earlier, do pada puja to the patient, touch the dasalis pedis. If it is absent, coarctation of aorta and other things. And once when all these are possible, certainly we have to evaluate. But the percentage of the people are much lesser. Even in the younger age group, what we see is essential hypertension and not the secondary, it's much lesser. Of course, you have to dig into the history. Are you on any alternative medicine, steroids? They are all also, forming a component, a small component, especially in the IT group. They come with a little obesity, little elevated blood sugar and elevated BP on steroid. No, sir, I am taking this. This has been given by the WhatsApp group. So this is what we see surprisingly.
In fact, as a nephrologist, we see almost 70 to 80% of the patients, they visit somebody who gives native medications and promise them a cure of chronic kidney disease. They come to us at the end stage. In fact, it's a little surprising to see that patients with even diabetes and high blood pressure, they take alternative medications and then come to you.
And they hide, they won't even tell you. And if there is a complication, sir, I took yesterday crocin, may is it because of that? Then when you dig detailedly, then they will be telling us.
In fact, we generally see a lot of these patients who take this, but the amount of faith what they have in those people who claim to cure a chronic kidney disease is so high. And when they come with pulmonary because they don't take allopathic medication, is that when you ask them, at least now you understand that you should not get back to those and why not just try to save your life. He says, no, so they told that I should not take lemon, and yesterday I took lemon rice because of which I'm like this. You dialyze me now and then I'll get back to that place. It's very difficult. Madam, for you, in your practice with patients with diabetes, what common tests you do to tell them that their kidneys are fine or not fine?
A warm good afternoon to everybody. I thank the organizers for giving me the opportunity to be a part of this wonderful event actually. To my patients who are diabetic, actually as Sir pointed out, denial is the first thing which I notice in my practice. They don't understand that they have a disease. They go into apprehensive mode, they get scary and they don't. So to convince them as family practitioners, I feel we should spend a lot of time, and communication is more important to mobilize the patient and understand them and make them understand that they have diabetes and hypertension is nowadays a Herculean task what we are facing. Regarding the test, what I do, generally I do basic test. I ask them to measure the height, weight. Generally in Indian setup, we don't go only with the BMI. The waist-hip ratio is very important, which is often very simple to, it's a simple measure. If you have an inch tape at home, you can measure the waist-hip ratio, and knowledge about the size can be inculcated to the patient so that they can monitor at their house. It is very simple for, we need to have the body mass index, and as everybody said, the basic test, the urine test for protein, excretion of protein is very important. And I do, basically, I ask them to, if the patient is well controlled, I ask them to do the test at their home periodically, and once in 3 months, do a HbA1c, fasting blood sugar, and a urine test. Control they are, we can monitor the test and we can order the test, but generally, I do an annual visual screening for organs, which is often missed, because when they has all the they come to us with the very late presentation. So annual screening for eye is very important, apart from regular blood urea creatinine and the urine test what we do, and it is essential to monitor the uric acid as well. Because uric acid, diabetes mellitus, hypertension, uric acid is one of the important predictors of metabolic syndrome. So uric acid levels 6 months once, and the lipid profile, the bad cholesterol, as everybody knows, LDL is a bad cholesterol which needs to be checked on and off, and controlling that is very essential in the treatment of diabetes.
You said the urine analysis you do once in 3 months, and what urine analysis you will do?
For checking the proteins we do, and the protein creatinine ratio if we suspect albumin excretion in the urine.
Okay. See, as a nephrologist, a lot of importance is given to terminology called a microalbuminuria. In fact, many times we come across this word. To be honest, in the last 30 years, because, correct me if I'm wrong, basically because we all understand that in the early stage of diabetes, the second stage of diabetes, what we call, you start getting leakage of some protein in the urine, and you call that as a microalbuminuria, because that albumin is not identified by the routine dipstick what we generally do. But when the dipstick becomes positive, there is no point in checking for this, because already patients have moved on from a microalbuminuria stage to a macroalbuminuria stage. As a nephrologist, we see patients who are 70s and 80s and who have 30 to 40 years of diabetes calling us and saying that I would like to see you because I have got a kidney problem. Let's see what's what. And many of them they come with small tests to say that I got last year it was 35 and this year it's 45 microalbumin is excreted in the urine. I always end up in saying that you have been diabetic for such a long time, you're 60 years or 70 years old, is generally expected. And they get a lot of panicky to have microalbuminuric stage. What I always believe is that if the patient does not have macroalbuminuria, urine albumin dipstick is negative, he could have anywhere less than 300 milligrams of albumin excretion in the urine. Whether to identify that is 30 or 40 or 50 or 60 is not going to make any change in the management. You're definitely going to control diabetes well, high blood pressure well, you put them on AC or ARB, medication that to improve their kidney functioning or cardiac functioning and so on. In what way it is going to be of any help just because you do this test? As a nephrologist, I see a lot of patients getting panic out of this test. But as a family physician, a primary physician who take care of these patients, when you say a value of micro will be like this, how does the patient react to that urine report?
Actually, definitely, I'll explain it with a case scenario. A patient of mine, 1 month back, he had some injury in the hand, and he had a lot of painkillers off record with the doctor's prescription. Suddenly, his blood pressure was high. He was a known hypertensive patient. On to me for a fitness. Actually, I work as a factory medical officer, so after any ailment, I need to give a fitness. So he came for a fitness. On examining, his BP was 220, 120. Very highly resistant, and he is already on telmisartan twice a day. So I asked him, this is so high, and have you monitored your blood pressure? He said, doctor, no doctor, only now my blood pressure is so high. So I ordered him blood urea creatinine and all the other panel of tests. And to shorten supper at one time, rather than 1, they have given it as 10. And the patient went into a panic. So everything got, even I said, okay, you need to recheck the creatinine, but all the other reports were normal. As sir mentioned, there was no protein excretion in the urine routine. So I was confident enough that, and there was no edema. Clinically, the patient was good. He doesn't seem to be, clinical judgment is more important than the laboratory values, I feel.
Sure.
Because as physicians, we need to interpret the individual clinically rather than going with the blood test. I was sort of like, okay, don't get panicked, we'll repeat the serum creatinine. And the repeat creatinine came as 1.2, and finally the patient was relieved.
I think good that only the patient got panicky. I think you were very confident that you should reevaluate the situation. Very important, because see, the most important point what madam said is that see, medicine, the art of clinical medicine is slowly dying. People like Dr. Vandaman sir and Dr. Nadarajan, they keep that clinical medicine because they teach a lot of students. But the art of clinical medicine is dying because all of us became doctors basically because we would like to see the patient, take a good history, examine the patient and make a diagnosis. To tell you this, I had seen a patient long back, and who had this boy was 14 years of age, and for the age of 4 years he has been visiting so many hospitals for persistent leakage of blood and protein in the urine. He went on to hospital, underwent so many tests, got treated as urinary tract infection, glomerulonephritis, etc., etc. And ultimately he came to us, it's 10 years journey. And with kidney disease, kidney failure, I asked the mother only one simple question. How is the son studying? அவன் படிக்கிறான் டாக்டர், கண்ணும் தெரிய மாட்டேங்குது, காதும் கேட்க மாட்டேங்குது. So Alport syndrome was diagnosed with only one question. So when somebody has a problem, we all get on to investigations, go to this lab and get this, that test done, that test done, and so on. But the art of clinical medicine, I think that can tell to a great extent how you interpret the problem, how to examine a patient and take a good history. And it's always, though you talk of artificial intelligence to a great extent these days, I think the natural intelligence always prevails. Right? That nothing can equate a natural intelligence of all of us, irrespective of the field at which we are practicing. Sorry, please.
In fact, about 12 years back, a 12th standard student came to me pretty late in the night for a simple cold. She was grossly anemic. The mother said, yesterday only the child won the inter-school match in table tennis or whatever it is. Grossly anemic. For an affluent family having such anemia, I said, do a basic investigation including hemoglobin and creatinine. And it turned out to be 10. Father donated the kidney, and the girl has become a doctor now, and she even delivered now.
Oh, very nice to hear, sir. So.
Can I add a point?
Please, ma'am.
Sometimes we also feel that many drugs are over-the-counter drugs.
Exactly.
Okay, so people would have taken those drugs, and we will do a battery of investigations, and there also the investigations, especially creatinine and blood pressure or even sugars, they will be so high. So many drugs, over-the-counter drugs, do induce these toxicities. So I think as we were asking previously about present history, past history, family history, I think beyond that, first only we should ask about drug history.
Exactly.
Because many of them are facing these problems, and drug-drug interactions are many. So I had a patient like this who was just, who was admitted to a hospital, then discharged the previous day. The next day morning I went to their house, so patient complained of blood in the urine. He was lying down on the bed, he did not move, he did not have any injury, nothing. Complained of hematuria. So after all the history, nothing was there. So it was aspirin 150, then ecospirin 75, clopidogrel 75. So it is just a refresh of the summary and drug interactions and over-the-counter drugs, which is taking a major concern today, apart from the per se disease as such. And I think drug history should be a priority these days, because everybody knows medicine.
Not prescribe any medication without the doctor's advice. There are only few medication that can be dispensed without a doctor's advice. But here, unfortunately, it has been, anything can be purchased across the counter in most of the pharmacies. And even educated people, they don't have time to go to a doctor visit, spend some time and then take care of their health. They just, on the way to a cinema hall, they just go park the car, buy some medication, then they go. I always tell them that please understand that every pharmacy is not run by a qualified pharmacist. Who sits there is not a qualified pharmacist.
I'm a physician seeing. It is my duty to confirm the diagnosis, what is the cause for the kidney problem. And I was taken myself, I know it's my challenge. I should challenge, you find it what the problem. Generally we talk of this thing, connective disease or SLE and other Sjogren disease like that. I went to the history, she said after running 600 meters, immediately she fell down. Then she started vomiting. Then subsequently she was vomiting, not able to take feeds, not able to take in water also. Keep on vomiting, nausea like that because she not some problem, dehydration. So that came. Then we investigated, but whatever it is, I thought it is strongly the dehydration that is caused the problem that is called rhabdomyolysis because of fast running without practice, maybe rhabdomyolysis causing problem. Then subsequently we have done all the investigation and of course all the opinion were got and nothing found to be abnormal except the creatinine elevated. Then started giving fluids over 2-3 days, we came down to 1.5. Then I sent discharge, it came for 1 week later 1. Creatinine. No, we go with creatinine, particular negative. So that's a story. That's really I want to, in this forum, in this meeting, I want to tell the hydration is very, very important. Now you happen to see the bottles everywhere on the table. See, most of the bottles are gali. See, most of the bottles are gone because we have insensible loss. So 600 to 700 ml of water is insensible loss is there. Then you should take adequate hydration. 35 ml per kg. If you are 60 kg means, I will buy 2 liters per day fluid, not a plain water. Definitely, if you take adequate hydration in a non-kidney patient, I'm talking about, not telling you pure ESRD, please don't mistake me. Yes, I am talking about a normal individual with a normal diabetes hypertension. Minimum intake should be at least 2 liters to make the cells, everything function normally. So that's one of the factors for, we have listened to the discussion on CKD-U. That is CKD unknown origin. One of the causes is farmers and the sun, exposure, inadequate water. நம்ம தண்ணி குடிச்சோம்னா சின்ன பாட்டில் இருக்கும். நீ ஃபார்மர் வீட்டில் போய் தண்ணி பாரு, ஒரு சொம்பு கொடுப்பாங்க, ஒரு சொம்பு தண்ணி. கரெக்டு, அதை தான் நோய் கிடையாது. ஒரு சொம்புனா 1 லிட்டர் இருக்காது, அட்லீஸ்ட் 1/2 லிட்டராக இருக்கும். தண்ணி 1/2 லிட்டர் குடிச்சாதான் அவங்க தண்ணி தாகம் செய்யணும், அவங்க இன்சிபிள் கரெக்ட் ஆகும். நமக்கு இது போதும், நம்ம ரூம் ஏசி ரூம் இருக்கும், நம்ம 3 லிட்டர் போதும். ஸோ அப்போ வந்து அங்கே மக்கள் வில்லேஜ்லேயே எப்படி ப்ராக்டிஸ் பண்ணியிருக்காங்க பாரு, அதனால தான் நோய் அவ்வளோ இல்லை. அஃப்கோர்ஸ் இதெல்லாம் வந்து பைபாஸ் பண்ணி போனாக்கா ப்ராப்ளம் வருது. ஸோ மை கன்சர்ன் இன் this is adequate hydration is very important and prevention of infection is very important. So vaccination is very important. Why I am telling infection? The infection precipitates the illness that aggravates the kidney disease. Suppose kidney creatinine 1.2 irukkuchina or 2 kidney disease or milder irukku. If you develop an infection, they become 2 become 5 become 8. Is that triggered by the infection? How to prevent infection? 1, precautions. 2, the vaccination. So I insist on vaccination of all diabetic individuals, and adult vaccination is there. The influenza vaccine, pneumococcal vaccine, and hepatitis B vaccine, all should be taken care. Only then, if you prevent infections, if you prevent dehydration, I think 50% to 70% of the kidney disease will go off. So that's what my...
Definitely, yes. Because to add on to whatever you said, we live in a place where the humidity is very high. So we have got increasing amount of insensible water loss. So I mean, we need to compensate for, especially people who do physical activity like running or fast walking. I think they should definitely take enough and more water. Sir.
Additionally, drug history. Many of the people, youngsters, elders, the painkillers, Zerodol-P, Oviron, they just like that take like as though it is their brother and sister, and they don't even tell us, are you on any medicine? No.
Sure.
And they keep gulping it and they come back with problems.
Right, these kind of painkillers are called NSAIDs, non-steroidal anti-inflammatory drugs. I always tell them NSAIDs are worse than AIDS because they cause more problem. Yes, madam. The urinary tract infection, which is very, very common in women, like how much you see and then what do you do with them? Like, for example, let's presume a middle-aged lady comes with a low urinary tract symptom being non-diabetic, and what would you do? Like what do you tell them?
If a middle-aged lady with the she's not diabetic.
Non-diabetic comes with low urinary.
Okay. Are very prone to have urinary tract infections because they have wider genital parts so that they can catch up infections. And to a patient like that, we should monitor. Only if the patient is symptomatic, we need to give the antibiotics. We have to do a urine routine and a urine culture in these cases. If the patient is symptomatic and if the urine cultures shows a growth of organism which is significant, then we need to treat the patient, and we will not check the urine routine again or repeat the urine culture to know whether the infection has to be ideally be checked for blood sugars. Even if they are not diabetic, we need to check the blood sugars, and sexual history is also important in middle-aged women. If the partners are having any other infections, we need to check them as well. And if they have recurrent urinary infection, probably we need to see the cause of urinary infection. There could be some stones in the pathway infection. So all the other causes for urinary infection should be evaluated.
Well said, because recurrent infections in women, infection in a child or in a male needs to be definitely evaluated. Most important point to all of you is that especially children, when they go to school or to college, they generally don't avoid urine. They always think that when I go and sit in the commode and then pass urine, I would get urinary tract infection. Please understand that the source of the bacteria is not the closet, it's not the... So the bacteria, which is the colon, which is significantly loaded with the bacteria, definitely would cause the urinary infection. So I think you should encourage all the child. See, many times the parents always tell, the child takes the water to the school and brings back the same, because child is little hesitant to, if I take water, what would I need to pass urine and I would get into problem, because the environment is not very clear.
One second. Regarding that NSAIDs, I think though they are over-the-counter drugs, whenever they come for prescription, I think we should motivate them more for paracetamol than other NSAIDs, because paracetamol will get metabolized in the liver. And moreover, we get even paracetamol 1000 milligrams, where 300 is released immediately and 700 in the latter part. And the third point is, paracetamol is also an analgesic. It is not just an antipyretic, it is also an analgesic. So I think, especially after 60, and analgesic is much better than the other NSAIDs, which will contribute to the prostaglandins.
Something? So, sir, when you see a patient with an upper urinary tract infection, for example, a pyelonephritis, somebody comes to you with severe loin pain, high swinging fever, especially in a diabetic, what is your way of approach, and what would you like to tell the audience here?
We need to have a good glycemic control to start with. The drugs, the urinary mycosis, genital mycosis and so on. And we have to be very sure, especially in a male patient, he should not have fibrosis, he should not have any prostatic obstruction while using all these drugs. And in spite of that, if the patient develops, say, pyelonephritis or high fever and renal angle pain and so on, stop the drug and give higher antibiotic, parenteral antibiotic, and give adequate fluid and take care of them. And of course, we should hesitate to reuse for the same individual the SGLT2 inhibitors.
Suppose if you find a patient with high blood pressure and you find an abnormality, either a protein leakage in the urine or a high creatinine, you tell them to go and see a nephrologist. How keen the patient listens to you and how much they go to the specialist for further evaluation?
See, I always take little time along with every patient of mine. I tell them it is something like a heart attack. You have a kidney attack, be more careful. Use the word, the correct language, the patient gets really, it gets into their head. Most of the time, even for a TIA or a stroke, the patients are ignorant. You tell them it is a brain attack, be very careful. Heart attack, everybody is scared, immediately willing to get admitted. This is an area where things can go this way or that way. You may come back, you may not come back with good renal function. Be always under the shade of nephrologist and urologist if required.
Yes, sir, please. Closing remarks from you.
Yes, yes, sir. Actually, when you say we are seeing patients of different categories, then they become more upset. If you develop a heart problem, they won't upset. You get infection, kidney infection, no upset. But if you say you develop a kidney problem, they immediately cry. You see the changes in the solely. So what generally we do as a physician, to make give a reassurance. Slight elevation is protein is there, creatinine is there. Anyway, we like to check. I don't believe you 2 days time. I want to confirm it. So we'll go back and come back in. Sir, ஆமா சார் கொஞ்சம் குறைஞ்சிருக்கு சார். கரெக்டாக சொன்ன பத்தியா குறைஞ்சிருக்கு. ஒன்றும் ப்ராப்ளம் இல்லை. இன்னும் நெக்ஸ்ட் டைம் அவ்வளோதான் கொஞ்சம் சரிப்பா கொஞ்சம் ஏற மாதிரி இருக்குது. இது கரெக்டான பர்சன் வந்து நெஃப்ராலஜிஸ்ட்டு. நீ எல்லாத்தையுமே நான் பார்த்துக்கிறேன், ஒன்றும் ப்ராப்ளம் இல்லை. கிட்னி டாக்டர் இருக்காரு அப்போ சும்மா இல்லை சார் வேணாம் சார் நீங்களே பாருங்கள் சார். ஏன்னா கிட்னி ப்ராப்ளம் டயாலிஸ் பண்ண அவங்க அது மாதிரி ஒரு நோஷன். கிட்னி ப்ராப்ளம் சொன்னாலே டயாலிஸ் பண்ணுவோம். எப்பா கிட்னி ப்ராப்ளம் டயாலிஸ் பண்ணுறது கிடையாது, ஒரு ஒப்பீனியன் வாங்கிக்கலாம். ஏன்னா சர்டன் திங்ஸ் எல்லாம் அவங்க இவால்வேட் பண்ணுறதுக்கு. அதனால் வந்து நான் சொல்கிறேன், நீ போயிட்டு எங்களே வந்துரு. Come back because I want to make sure that he should go and reassure him. This is a way to reassure my patient. Then go back, go there. So once they get into it, they become convinced. The first time only the refusal, as sir said, denial not only for diabetes, more and more denial for a kidney disease. Heart problem சொன்னா பயப்பட சார் ஈஸி நல்லா இது சார் நல்லா ஃபிட் சார் ஐ பிசிக்கலி ஆஃப் देम
ஸ்டென்ட் கூட பண்ணலையா. Wow, so he becomes a person to say that boss you are not supposed to be fit in this elite audience, right? So when the acceptance rates of either a stenting or a coronary bypass surgery become a norm, as you rightly said, the word dialysis takes them away. I always tell them that if the bypass surgery has made you live, dialysis is also going to make you live. I always tell them that kidney disease is bad, but the best aspect of the kidney disease is there is a treatment. Irrespective of whatever be the disease, whether this is a temporary kidney disease or it's a permanent kidney disease, at whatever the stage be it, and you have a treatment for the disease. It is not a disease which is going to put a full stop to your life. If you get treated properly, there is life beyond the kidney disease. I always tell them, instead of looking at cup as half, look at change the perception. I am not going to, you can live a normal life is what I always tell. Most important thing than a doctor telling a patient is that the most important thing is a patient who has gone through this sits with him and then talks to more than a counselor, more than a doctor. I think a patient who has gone through this problem and then come out successfully, if they talk to them, that's the biggest reassurance what they can have. Madam, your closing remarks, please, both of you. Anything you would like to say to the audience?
I feel basically every person should be checked for blood pressure, where we don't lose anything at all. And we have to have a good history. Nowadays history is lacking from every doctor, history is lacking because of lack of time, and the person is also on an urgent basis, more so on a telephone or a WhatsApp call. So history still remains the cornerstone of any treatment or diagnosis. And BP should be checked for every person, and the basic investigation should be done, not the battery of tests. Once these basic investigations, about 5 or 6 which are there, if that is done and the patient is convinced, like what sir told, the communication skill which is lacking today, if that is brought up, then I think we can prevent many of them rather than going to the treatment aspect as well.
What I feel is that diabetes and hypertension, as everybody has mentioned, is a silent epidemic. And to control the silent epidemic, it is the patient, it is the individual themselves who should take the responsibility to screen themselves. Blood pressure machine is is less expensive. Everybody has sugar glucometers at their home. They can check that periodically, once in a while, and if they have any abnormality, they can have a family doctor so that they can connect with them periodically and monitor their health. And of course, in spite of effective and proven treatment, many of the patients are hesitant to take medications, and they are very apprehensive in taking medications. I think the idea of taking medications, the side effect of medications, they get scared of the side effects. I think that aspect needs to be that aspect of taking medicines to be more awareness should be created on that, and more towards self-prevention methods should be done.
Right, sir. You guys have closing remarks.
Many of us forget the the basic clinical medicine. First thing, we don't even ask what is your problem. The patient comes with a massive checkup. Doctor, look at it and treat me. Hey, what is your problem? Sir, look at it and give me the medicine, sir. So, first thing, we have to go with the detailed clinical history, family history, drug history, and then the basic clinical examination, look at anemia, basic BP, and then move on with the laboratory. The culture is slowly changing to the bad, especially the youngsters and IT people. Master checkup, look at and tell me. And most of the master checkup do not even have ultrasound kidney, ultrasound ECG, nothing. They give battery of blood values, which may be normal, may not be normal. This is what we see, which we have to change it by ourselves working hard.
Very good thing, because the Dr. Google is one doctor who is very popular with all of us. We always get on to Dr. Google and find out what is wrong. They come only to us for a second opinion. I'll just finish this. In fact, we see a lot of people who come with this Dr. Google's diagnosis and come to us. In fact, one elderly gentleman who was 75 plus, who came to me saying that he had been having vomiting, so he went to the neurologist, got an CT scan done, he went to the gastroenterologist, got his endoscopy done. So he thinks that vomiting could be due to the kidney disease, so he just came to me and forced me to do some investigation, which turned out to be normal. I told him that you should go and meet one more doctor, and you could have vomiting because of this. He said, tell me to whom I should go. I said, go to an obstetrician, because vomiting early in the morning, especially with pregnancy. He's 75 gentleman. He just hit himself and then said, Dr. Anderson, what you're trying to say. Yes, sir. You have something to say?
I call them idiots. I call them idiots. Internet-derived information obstructing treatment. Right on the paper, they learn it.
And again, please, sorry. Go ahead, yes, madam.
No, I want to know, we don't have enough GPs.
Correct.
Now we want to know why to visit family doctor.
Very important, because yes,
that is because all people who are finished MBBS, they want post-graduation. Nobody wants to open a clinic. And during house surgency, they don't do any practical aspects for many reasons. So then they jump to PGs where it will be funnelized. Then they go to super specialization. So these are the problems which are encountered, and they want the further things rather than opening a clinic and practicing at that level and seeing the patients.
We want more GPs.
Yeah, definitely, yes.
The other reverse is also there, too. The reason is, when you have any problem, suppose headache, he is going to a neurologist. If you have abdominal pain, goes to a gastroenterologist. If you have chest pain, goes to the heart disease, cardiologist. If that happens, who will remain as a GP? Everyone wants to become a specialist because vocation has to be referred. So the problem is also like this. Nowadays, most of the time they go with the pain, shoulder pain, with a neurologist. For shoulder pain, why neurologist? So when people are changing, the doctors are also changing, the culture is completely changed. Now we go back to the original state, general practitioner, and of course hospital based, something like that. That's always safe.
I'll give you a real case scenario about 8 years back. An elderly gentleman, he had headache for 10 years. He had been to ophthalmologist, he had been to neurologist, he had been to ENT, everybody. When he came to me first time, I checked his BP, it was somewhere around 220/160 with a frank renal failure, and he boldly said, I don't think I have any problem. In fact, he died in 6 months' time. This is what happens. Directly they go to shoulder pain, running to cardiologist.
See, a good general physician, a family physician is, as you rightly said, is the need for the other. See, specialists can do only few things. When the problem becomes to the next level or to the next level, we can do only those things. But a patient should go to the family physician who knows the complete history of not only that particular person, the entire family. And that he can decide what is the nature of the problem and then go to a problem. The problem here is, as I said, a patient has a headache, goes straight to the neurologist, and the neurologist is forced to do a CT scan or an MRI scan to know what is exactly the problem. And the CT scan sounds to be normal, and doctor gets the blame. சாதாரண தலைவலின்னு போனே ஸ்கேன் பண்ண சொல்லிட்டாரு, 10,000 rupees காலி ஆச்சு. So doctors become the villain there. On the contrary, if the doctor says that it's a normal headache, you just take a medication, then you go. And then unfortunately it turns out to be a brain tumor, which is identified in the next place. Then the doctor also gets the blame. I went to the neurologist, he said it's a minor headache, and then he said, you didn't do a CT scan. So even the doctors are at fault. All these problems can be solved if the patient goes to the primary physician, like family physician, and then gets himself evaluated. He is the best person to direct where to go, when to go, and what to do. And always the specialist should ensure that he or she writes in detail what is the problem, what he thinks about the patient, gives a complete letter, and then send the patient back to the primary physician so that he can understand what is happening to them so he can guide properly. As a specialist, we cannot handle the entire burden of diabetes or high blood pressure or ischemic heart disease or hyperlipidemia, etc., etc. It's not possible for us. The best person is a family physician. I think some of the take-home messages today are: one, spend at least 1 hour for yourself every day, at least 5 days a week. If you are not doing that, please do that. Second, please avoid over-the-counter prescription, because the person sitting there is not a doctor, is not a pharmacist. And third and fourth most important point is, let's all do a preventive medicine. I'm sure the next agenda is to have lunch. We've got enough foods that we talked against in the last 4 hours. Many of the foods have high salt, many of the foods have high cholesterol, they have high carbohydrate. I wish you choose your diet. I thank the Kidney Virus Foundation for the excellent opportunity what they have given to us. And I thank all for taking all the questions. I'm going to explain to you in a very great way. And let's all live healthy. Thank you very much. God bless all of you. Thank you.
Thank you very much for that session so beautifully. Can I request Dr. Jignesh from the dais? Dr. Jignesh, can you please do the honors of presenting a small memento to our panelists on stage, please? This afternoon's program, and all of Nephroplast Tanker Foundation, Moon Foundation, the Kidney Foundation, and they take the opportunity to thank each one of you who've taken the effort to be here this afternoon. I'd like to thank our medical specialists, our general practitioners and family physicians, and of course the respective media for joining us to take this message to beyond this room. This is me, your MC, Mary Ann, signing off, wishing you all a very good afternoon once again. Thank you, and please join us for lunch. So big round of applause to Mary Ann for taking this through so beautifully. Thank you, Mary Ann. You've done a great job here, and all our foundations are really grateful to you for all the efforts that you made in coordinating this whole thing, along with the team, everybody. We thank everybody, but you need a special thanks from us. Can I get a, I think we need to honor her. So can Hemal come up? And if somebody can come from all the foundations, let's honor this beautiful MC of ours who not only, just organized it, but put everything together. Come, ellarum mele poi kudukalam. Thank you. Come. Emil, come. Yeah, she needs a shawl as well. Yeah, this whole team, I think we have to really congratulate the Kidney Warriors team, every person. Nephro Plus, is there anybody from Nephro Plus? So the bag, where's the bag? Yeah, here's the bag. Is there anyone from Nephro Plus here? Okay, so Vasundhara? Yeah. Boringa? Sir, can you come? Thank you. I think you made this whole show possible today. So, please honor Mary Ann. Yeah. Thank you for your support. Come, let's take a picture together.
But couldn't have done with you without you.
Yeah. Come.
course, our inspiration is Vasundhara, who heads Kidney Warriors, so thank you so much. I think everybody's been inspiring, but thank you. Okay. Yes. And we are going to have a good lunch and eat everything. Today is cheat day. Thank you.
After doctor said, watch out what you eat.
It's just so balanced.
I've got blood sugar.
Thank you.